And as you are coming into our Zoom room, if you could kindly just mute yourself so that we can allow for a very free-flowing day, and just turn off your cameras where possible, please. That would be greatly appreciated. So once again, welcome to our conference. Welcome to the Place of Philanthropy and Community Mental Health. My name is Irina Hovrenkov, and I'm an associate professor with the Johnson Shriyama Graduate School of Public Policy at the University of Regina. My colleague and co-host of this conference is Dr. Lynn Gidluck, who leads the University of Regina's Community Engagement and Research Center. And we're just so delighted to welcome you to our event. We're thrilled so many people from across the country are able to join us today, and we're really excited to learn where you're joining us. So if you could kindly fill out a short survey, which will be posted in the chat box, just for us to learn a little bit about the demographics, that would be greatly appreciated. While our event is virtual, it is important to acknowledge that we, as your hosts, are located in the Treaty 4 territory in Regina, Saskatchewan, the traditional home of the Niiwak, Anishinaabeg, Nakota, Dakota, Lakota First Nations, and homeland of the Métis. I would also like to acknowledge that this conference is sponsored by the Canadian Philanthropy Partnership Network, which is a national research network supported by the Social Sciences and Humanities Research Council, and also a number of grant-making foundations and organizations working to advance the interests of the philanthropic sector. Together, Lynn and I are the co-directors of the Western Hub of this national research network. All of the projects that receive funding from this network have to pass the Community First test, where researchers must demonstrate to the funding committee that community-driven needs are at the heart of the work they propose to do. Community partners play a key role in defining the research questions and ensuring that the projects meet the needs of the communities they serve. And so one of the goals of this conference is to bring together communities, researchers, colleagues from academia, and members from the grant-making sector to share information, resources, and ideas. And with no further delay, I would like to introduce you. I'm so honored and delighted to introduce you to our two fabulous keynote speakers, Margaret Eaton and Dr. Lindsey Richardson, who are very accomplished women. Margaret Eaton is a national CEO of the Canadian Mental Health Association. Under Margaret's leadership, CMHA ranked 6th on the Forbes list of Canada's best employers. And in 2021, Margaret was named one of the Hill Times top 100 lobbyists. It is real testimony to the work Margaret has done in propelling the topic of community mental health to the top of the Canadian public minds this past year. Dr. Lindsey Richardson is an associate professor at the University of Regina, or the University of British Columbia. Lindsey, you're such a wonderful academic. We probably want you at our institution as well. And she's also a research scientist with the British Columbia Center on Substance Use. Her research has been extensively published in many leading academic journals. She has been interviewed numerous times by the mainstream media and made many public appearances to share her research, which connects substance use with social determinants of health. Margaret and Lindsey, welcome to our conference. And thank you so much for making the time to share your perspectives on the issues around mental health with all of us. I would like to just quickly note that only the presentations will be recorded today. We will not be recording the question part of this session, just to allow for that free-flowing and sincere discussion. So with no further ado, I would like to pass the torch to Margaret to make her keynote address.
Thank you very much, everybody. I appreciate your patience. And I'm really delighted to be here to speak with you about the mental health impacts of COVID-19. So today I want to talk a little bit about the CMHA, if you don't know about us. I want to talk about the impact of COVID-19 on mental health of Canadians, but also the impact on our organizations, how the government responded, and what we hope might happen next. So to tell you about us, we were founded in 1918. Curiously, we were founded in the middle of the Spanish flu pandemic, right after the end of the First World War. We are now in 330 communities across 10 provinces and the Yukon Territory. And we offer a range of programs, services, and supports to over 1.3 million annually, including our Mental Health Week promotion, which we just had in May, which encouraged people to name it, don't numb it. So name your feelings as a better way of dealing with them than numbing them. So to tell you first about the impact of COVID-19 on mental health, we worked with UBC on a series of research reports where we tested the waters with Canadians approximately once every 4 to 5 months, starting last June. And the numbers were fairly consistent when we look at what the impacts are. So the general population, Canadians overall said that 41% of them had experienced worsening mental health. But our particular interest was with vulnerable populations. We had seen a lot of research that talked about how were Canadians feeling, but we particularly wanted to know, was it worse for people who were in a more vulnerable situation? So you can see in this slide, people with a pre-existing mental health condition were faring much worse. 61% of them said that they had worse mental health. Similarly, people with a disability, households with children less than 18 years old, parents, the LGBTQ community, people who are unemployed, of course, and women. If we look at women's mental health versus men, 44% of women said that their mental health had worsened versus only 32% of men. That could be because women are more comfortable talking about their emotions, but it could also be that, as many commentators have noted, the impact of the pandemic on women's mental health seemed to have been worse. Women oftentimes ended up caught between a job and taking care of children, especially with children being out of school. They also disproportionately have to support their parents and the elder population. And so women were really feeling the squeeze. Women also were more likely to have lost work during the pandemic in traditional areas like restaurants, hospitality, tourism, where women are overrepresented. This was a sad one. There were concerns amongst 18% of the population about having enough food to put on the table. And that was the scary part of the shutdown of the economy. And if we look at suicidality, in any given year, about 2.5% of Canadians say that they have suicidal thoughts. During the pandemic, that number rose to 10% of the general population. And if we look at vulnerable populations, again, you'll see those numbers are much, much higher. And we particularly looked at the impact on parents. 45% of parents said they were stressed because of financial concerns. We saw an increase in alcohol consumption around this group and an increase in suicidal thoughts, 9% of parents saying that they had suicidal thoughts. So why do we feel so awful? Well, it's all of these things and the combination of these things. Social isolation has been huge. We found out just how dependent we are on each other, and being apart from each other has been painful. There's been lots of fear of the future and the unknown, not really knowing when it will end. And thankfully, we're seeing a little bit of a light at the end of the tunnel now. But there's also, with that, a fear of returning to normal. So what will it be like when we try to get back into the world, when we've been out of the world for so long? There are, of course, health concerns for ourselves, for our family, for friends, financial concerns, which are huge for many people. Wages, rents, loans coming due. When we saw the wage subsidy come through from the federal government, we saw that as a mental health program so that people would have that financial, social determinant of health, having the financial means to carry on. There's been tremendous change for many of us in white collar roles. The pivot to working from home has not been an entirely perfect. There's boredom and monotony. And there's lots of grief from loss, of course, from death, but also from lost opportunity and a feeling of lost time. So if we look then at charitable organizations and CMHA in particular, what impact did it have on our CMHAs? We have 86 organizations across the country, all carrying a heavy load during this time period. One was there was a much more increased demand for our services. So as you can imagine, the phones were ringing off the hook at our CMHAs very shortly after the lockdown began. In some places, calls were up 100, 200% over previous times. And in terms of our suicide lines, some of our CMHA branches are part of the National Suicide Crisis Line. Those numbers were incredibly high as well for people wanting counseling and support through suicide ideation. We heard from new people, new clients that we had not heard from before, people that were not normal users of our services. And then in addition to the mental health demand, there was also a lot of demand on our CMHAs from governments. So provincial and regional local governments asking us to sit on tables. There were so many new advisory groups that were formed in order to find out what should we do next. And so CMHAs were called on, in addition to meeting that client demand, to actually meet the demand of government. And similarly, media requests were also up across the country as the media wanted to cover what was going on in mental health. Of course, we all pivoted to virtual services. During total lockdown, programs that would have been delivered in person switched to virtual, and that was a new experience, especially for clients who might not have had the technology. There was a rush at CMHAs to try to fill the technology gaps for those who might not have been able to afford or have access to those services. So some of our branches are very proud of the fact that no programs were dropped, that they found ways to deliver. You know, some of them were delivering food. They were concerned about clients who would have come to their drop-in centers, their clubs, and concerned that they weren't getting enough to eat. And so our staff were doing things like packing up sandwiches and making sure that clients had food. So that was a tricky turnaround, but one that we're very, very proud of. Thirdly, government funding and corporate donations in particular, and individual donations increased. And that's a wonderful thing in many ways. This happened at the national office as in addition to the regions and branches. And sometimes it was donors calling. We had one saying, here's $250,000. Do whatever you need to do to help people out at this time. And so we were able to distribute that funding across the country. And it was unrestricted, which was very powerful for us because it meant that money could go out and be spent in very different ways across the country, depending on what the needs of the organization were. At the same time, too, the double-edged sword of new funding, especially if it's program funding or restricted funding, is you have to spend it, which might mean getting out and hiring, starting up something brand new in place of what you were doing before. So that also created additional stress. And finally, our staff are feeling burned out and stressed. I've heard this across the country, that it's been a really hard, long year. And while we're delighted with the success that we've experienced, it's been a tough go for everyone. So how are governments supporting community agencies and really stepping up? Well, we were very pleased that both the federal and provincial governments across the country have invested in mental health funding. And we saw big increases in funding, for example, for our Bounce Back program, which is a virtual cognitive behavioral therapy program. This program was funded in Ontario and British Columbia, but there was new funding in Quebec, in New Brunswick, and we got some national funding for Bounce Back to ensure that everyone across the country has access to that virtual program. In 2021's federal budget, there was almost $1 billion allocated for mental health. And even separate above and beyond that, we saw another $400 million to create this temporary community services recovery fund. And I think this is to help those organizations that saw reduced funding, unlike CMHA, which all of us across the country saw increased funding. Some charitable organizations actually saw quite a large drop in funding and laid off staff. So this is to provide some additional support to agencies who are helping their clients to recover. And we're still waiting for details on what this might look like and how it will roll out. But we've been really excited that there's been this recognition. And I would say beyond that, in our conversations with the government, there was a real sense that they're concerned about mental health and that this is a priority for them. And that they were also very concerned about funding grassroots organizations. The way that the Canada Health Act works is that funding for mental health comes through the federal government in the form of transfers to the provinces. The federal government had made a big increase in mental health funding, but they didn't know how it was being spent, whether the provinces had actually spent it on mental health and what the impact had been. And so there was very much a desire on their part to reach out to grassroots organizations to be able to fund directly and have a direct impact on mental health, sort of circumventing the provinces, if you will. So just as an example of that, the Public Health Agency of Canada has $100 million to support vulnerable populations who have been impacted, their mental health has been impacted by COVID-19. So we're very much hoping that our community mental health agencies, not just CMHAs, but others, will have access to that funding, which could be substantial and transformational for vulnerable communities. So we're happy to see this sort of switch in thinking at the federal level to recognize the importance of community mental health. So what should happen in the longer term? Well, we're very concerned that the long-term impact of COVID-19 will be profound. We've talked about the echo pandemic of mental health. And what we found in the case of other kinds of epidemics or natural disasters is that even after the physical effects have been mitigated, even if we're going back to work and things feel normal, it's at that point that people oftentimes find that they experience the worst of the mental effects of the situation. So for example, in Fort McMurray, after the fires, we found that even after people had returned home and things were kind of back to normal, it took up to 18 months to 2 years for those who had been experiencing that awful occurrence to actually get back to better mental health. So our phones in our branch, our CMHA branch in the region, we're still getting calls from people up to 2 years later. So we think that the same thing will happen through the pandemic. And it will be a tough transition for many people to go back to work, back to school, to feel comfortable, and to put aside those anxieties that they felt over the last year. And we know that economic recovery will depend on having a well workforce. But even aside from the pandemic, we were all struggling with mental health well before the pandemic. Our research shows that 1.6 million Canadians reported unmet mental health needs prior to the pandemic, and that would be annually. 85% of Canadians believe that mental health services are underfunded. 53% of Canadians believe anxiety and depression is epidemic. And mental illness has a high cost for our economy and our society, with depression growing. So that was happening before the pandemic. And what we see through this pandemic is a kind of opportunity that because so many people have experienced anxiety and depression, that it has normalized what many people live with on a regular basis. And so there is a feeling amongst all of us here that the time for us to make a big change and to ask for a big change of governments is now. that we really need to take advantage of the moment and the opportunity that COVID-19 has afforded us. So we're looking for a long-term solution, and we believe that it is universal mental health care. Our current healthcare system really provides fairly inadequately for mental health, and I don't think people feel that there is a clear pathway if you have a mental health concern or a challenge. And what people really want is a kind of one-stop shop. They don't want wait lists. They want to know where they can go to be seen to get help immediately. Almost like having triage or an ER, or, the same sorts of things that we would have. If you broke your arm, we would know exactly where to go and what to do and what kind of help to expect. We should have the same kind of thing for anxiety and depression, which are sort of like the common cold of mental health. Other countries have this. I was very fortunate to be in Germany and speaking with a young person there who is a tour guide, and he told me that he formerly had been a dancer. And I said, "Oh, why are you not dancing now?" And he said, "Well, I had some mental health issues, and so I got some help. And it was wonderful to be here in Berlin. There were fantastic supports for me. I got all the help I needed. I got some employment help afterwards, and I got a subsidy to my wages so that I didn't have to worry about finances while I was taking care of my mental health." And I just thought, why don't we have that? First, he spoke so openly about his challenges with me. We'd barely met, and he was telling me about mental health issues. And he found that wraparound care that he needed that I would love to see all Canadians have. We also believe with that, the community mental health organizations should play a key role. That mental health isn't just about doctors and hospitals, but it's about funding a community approach, a wraparound approach, so that community care, which has been longstanding in Canada, as I mentioned, over 100 years, we've had community mental health care that has been trying to fill a gap that the regular health system has not filled. That needs to continue, but with appropriate funding and with appropriate connections back to the regular healthcare system. So we really hope that mental health will be more of a priority. There's an election, a federal election coming up this fall, and we are now getting prepared to really make the case for universal mental health care for all and for a fully functioning and appropriately working mental health care system where all Canadians feel that they can get the help that they need when they need it. So thank you very much for having me here today. I look forward to your questions. Thank you again for your patience as I fiddled with my technology. And I look forward to hearing Lindsey. Thanks so much.
Thank you so much, Margaret. This was quite informative. I kept making notes because I really like the idea of this universal mental health care, which something that I haven't heard before. So thank you for sharing that insight, that interesting solution. I would like to pass the torch now to Lindsey, Dr. Lindsey Richardson, to make her presentation.
So thank you so much, Margaret, for setting the stage and for talking about what has happened around mental health in Canada during the pandemic. I think we've all felt these shifts, and it's so helpful for you to provide information and put numbers to what I think we've all been experiencing on some level. I'm going to be speaking to intersecting epidemics in Western Canada, specifically around COVID-19, around the opioid overdose epidemic, also mental health, and a little bit of other things that we should be not losing sight of. And I hope also to touch base on potential multi-sectoral responses and how we should be thinking about responses to multiple intersecting epidemics that we're currently witnessing across Western Canada. So I'm briefly just going to acknowledge that I am coming to you from the unceded ancestral territories of the Coast Salish peoples, including the Musqueam, the Squamish, and Tsleil-Waututh. And what you're looking at right now is a picture from a memorial way back in 2017 where things were already quite bad in terms of the overdose epidemic in British Columbia, but the worst was yet to come. We really didn't know what was happening. And each of those stakes represents a life lost between January of 2015 and September of 2017. This is often the face of what we think about when we think about the overdose epidemic. So this is someone who has gone down in an alleyway in downtown Vancouver and is being responded to in a particular way. But as we have learned, it is not something that is concentrated in Vancouver's downtown east side or in inner city areas in municipal communities across the country. It is something that we are seeing in rural and urban spaces across Western Canada. So what you're looking at is the illicit drug toxicity death rates by health service delivery area in British Columbia in 2020 and 2021. And I show you this just to illustrate that it is a provincial problem in BC, like it is a provincial problem in Alberta and Saskatchewan and Manitoba. And it has gotten so bad that in April of this year, the BC Centers for Disease Control had to change the scale. So you can see in the middle, there's the scale, and the highest rates are in that dark brown and the lowest rates are in the sort of light yellow. And it used to only go up to 30, and we had to change that because the entire province was dark brown. And so we're constantly having to shift our metric of how we're understanding the magnitude of this problem. This was what was happening in 2019 before the pandemic. And in 2019, we actually saw overdose rates go down from 2018 slightly. And so there was much cause for optimism. We thought that what we were doing was working. And then, of course, COVID-19 hit. This is what the map looks like for the first 9 months of 2020. We don't have data beyond that. There isn't a map that goes beyond that. And we don't have data that goes beyond that from the federal government at this point. But you can see already that in the first 9 months, things were already way, way worse than they were in 2019. I've pulled the data that is available, and this again only goes to the end of September of 2020. These are the numbers of people who lost their lives to opioid-related deaths in Canada, in the sort of dark gray, but I've pulled out the information for each of the provinces. So British Columbia in blue, Alberta in red, Saskatchewan in yellow, Manitoba in green. But I think it's really important not to just be thinking about absolute numbers of lives lost here. I think it is much more informative to think about the rate. And the rate is often measured in the number of deaths per 100,000 people. And so these are the rates of death from 2016 to the first 9 months of 2020. And we see, again, there was a slight decrease in 2019, but that rates are really, really high. What we're seeing is way worse, for example, than what we saw at the height of the HIV epidemic. And so these are numbers that are very alarming. I also ask you to remember that 33.5 that British Columbia was at in the first 9 months of 2020. Just hang on to that number as a point of reference for the next slide. So what's happened in 2021? It's worse than 2020 so far by a lot. So these are the numbers for British Columbia. This is the pattern since 1995. And what you can see is that line shows the anticipated rate of death per 100,000 people in the population. And we are on pace to far exceed what happened in 2020, which was already the worst year on record. In April of 2021, there were 176 suspected deaths, the largest ever recorded in the month of April, and a 43% increase over April of 2020. In Alberta, this is the monitoring data from the Alberta government. We similarly saw during the first 2 months of 2021, a surge that was 153% higher than January and February of 2020. In Saskatchewan, we are seeing a similar pattern. I note that those yellow suspected deaths almost always become blue confirmed deaths. And this is why I wanted you to remember that number, that 33 number for BC's rate in 2020. If Saskatchewan's current trends hold, they will be at a rate of 31.9 per 100,000 residents this year. This is unfathomable. And when we look to Manitoba, one of the things that you will discover as a theme for Manitoba in this presentation is that data is pretty hard to come by. I was able to identify that the data from 2020, where 372 people lost their lives to overdose in the province, but I wasn't actually able to find any data about 2021 at all. And I just want to emphasize that we are really hard pressed to respond to things that we aren't understanding and aren't tracking. So this lack of data is quite alarming. And I know community organizations in municipal spaces in Manitoba are really sounding the alarm, but the provincial government isn't really responding with the kinds of monitoring and responses that we would hope to see. I also want to talk a little bit about how drug poisoning intersects with mental health. And I use drug poisoning and overdose somewhat interchangeably. I'm trying to move much more towards the language of drug poisoning, because what we are talking about is a toxic drug supply that is poisoning people. And my team over the last couple of years has done a systematic review led by a postdoctoral student of mine on mental health and opioid overdose, both fatal and non-fatal. And what we found is that when you break things down by type of mental health disorder, there does seem to be a relationship, a positive relationship, in that if people have mental health challenges, they also seem to have higher risk of both non-fatal and fatal drug poisoning. And we also found that the relationship is very complex from a directional perspective. Do people develop mental health challenges because of their substance use, or are people responding to mental health challenges with substance use? It's a really difficult puzzle to disentangle. We're going to revisit this a little bit later on when I talk a little bit more about multisectoral responses. So I've given a bit of an epidemiologic snapshot of what's going on in Western Canada. And I want to offer sort of two key considerations in how we should think about what is going on with the drug poisoning epidemic. The first is that fatal illicit drug poisoning is a really low bar. We shouldn't really be thinking just about preventing death. And that's because the consequences of non-fatal poisoning are severe and chronic and widespread. And we've seen significant increases in opioid hospitalizations in particular. I've listed some of the drug poisoning morbidity that we keep our eye on there for information. And it's really important to know that emergency responders in Canada in the first 9 months of last year responded to over 20,000 drug poisoning calls. Again, these are numbers that are pretty unfathomable, and we shouldn't really be thinking about just preventing death. We should be thinking about preventing drug poisoning to begin with in non-fatal, for both non-fatal and non-fatal outcomes, or non-fatal and fatal outcomes, excuse me. The other consideration that I really ask people to hang on to is that drug poisoning is not affecting all groups equally. So what you're looking at on the left is an infographic that was published last month by the First Nations Health Authority in British Columbia. And it really emphasizes the degree to which this is being borne disproportionately by First Nations communities in BC. We know that most poisoning deaths occur among men and young men and people who are living in poverty. And while most provinces don't collect data by ethnicity or socioeconomic status, where that data is available, as I mentioned, Indigenous populations are disproportionately affected, especially Indigenous women. And one of the things that we should really be thinking about is not about individuals and individual risk behavior. We should be really thinking about the degree to which our systems, our social systems, our community systems, our government systems create, through their policies, gender differences in poisoning risk, how the effects of racism on how people access care has adverse consequences for their poisoning risk, and that people are faced with inadequate and underfunded social and health services. And so we really need to be thinking about this from a health equity perspective about which populations are being affected, which populations are being underserved in terms of our efforts to prevent drug poisoning. So that's sort of the first section of my talk. I want to give everyone just a moment to take a breath because it's a lot of information and it is not good news at all. So things were bad already. After COVID, they are getting worse. And I'm going to spend the next part of my talk really introducing the idea of a syndemic. And so this is a term that for people who work in health, you will likely know this already, but it's an important one for people who don't work inside health to start to think about how we are managing multiple fronts in physical and mental health simultaneously. And so a syndemic is what happens when you have the co-occurrence of multiple epidemics at the same time that interact and worsen the effect of one another. And so I've identified here substance use, COVID-19, violence, adverse mental health. I'm not going to talk about violence or adverse mental health so much because Margaret gave us a great snapshot already about that. And violence is a little bit outside the scope of my talk for today. But we are seeing data that shows how these epidemics are reinforcing each other through the social factors that create the conditions that make people more likely to experience these things. And so what happened during COVID-19? So what we know is that people were at increased risk of severe COVID-19 illness if they had a drug poisoning history. They were more likely, for example, to have the 4 conditions that are known to increase the likelihood of severe COVID-19 illness. So that's the first piece to think about. The second is that there was increased COVID-19 illness among people with substance use disorder. This research comes from the US, but what was indicated by the study that was led by Nora Volkov was that people with an opioid use diagnosis were 10 times more likely to have COVID-19. And that is true for almost all substances for which we have use disorder criteria in the DSM. So that's the second piece. The third, and I think everyone has direct experience with this in this room, is that there were reduced or suspended social and health services. So services had to reconfigure to distance supports. Some were unable to provide the kinds of services that they had been providing because of what was going on with the pandemic. And that often removes a source of stability for people, which increases stress, leading to potentially higher risk of mental health challenges and or substance use. So that's the third piece. Fourth is that elevated stressors often increased substance use at a time when there was lower treatment access. And this is an article that came out in the New York Times late last year, but it really spoke to how substance use has increased during the pandemic, often as a response to increased stressors and increased challenges for mental health, and access to treatment is significantly lower. And it's important to remember that a lot of treatment and recovery for substance use happens in social settings that support people's healing processes, and that COVID-19 has conspired against that. Another piece to think about is all of the public health directives and physical distancing measures that we have all had to contend with over the last year, more than the last year at this point. It is very difficult to engage in physical distancing or to adhere to public health directives if you are socioeconomically marginalized. And that includes having timely access to accurate information, access to personal protective equipment, hand washing facilities. I mean, it's very difficult to shelter in place or to stay at home if you are homeless. In addition to that, people were more likely to use drugs alone. And that, before the pandemic and during the pandemic, has been documented as one of the most significant risks for fatal drug poisoning. And so for physical distancing purposes, on top of all of that, people use drugs often avoided using available services. And so what we see is this real configuration of higher vulnerability, elevated stress, elevated substance use, lower access to services, and public health directives that were really important for COVID-19 management, but really not good for substance use disorder management. And then you add to that rapid changes to the drug supply. And we already knew that the drug supply was toxic before COVID-19. And with closed borders and interrupted supply chains, the drug supply has become more toxic. And this has involved the devaluation and decreased production of drug crops, the increased of synthetic production and increase of domestic production. And so we've seen, for example, we already knew that there was a lot of fentanyl in the drug supply. What we're seeing now is also a lot of synthetic benzodiazepines in what is being sold on the street as an opioid. And so we know that that is increasing people's overdose risk as well. And we see this in coroner's toxicology reports. So from people's autopsies, we're seeing elevated rates of extreme concentrations of fentanyl in those autopsy reports. And so when we think about what has happened around mental health and COVID-19 and substance use, it is this complex intersection of people and infectious disease and stressors and drug markets and socioeconomic and institutional environments and public health directives and broader public policy. And it has really created the perfect storm, and we are now bearing the brunt of what is happening as a result. So again, I'm going to give us a moment to take a breath and have just a quick pause. And for the next portion and the final portion of my talk, I'm really going to focus on solutions and what's been done and what's being done and how we should be thinking about things moving forward. So what was in place before COVID-19 hit were a lot of different measures. There were a lot of really wonderful concerted efforts in trying to address substance use, risk of non-fatal and fatal drug poisoning, et cetera. And what you're looking at here is a map of supervised consumption sites and overdose prevention sites in Western Canada. And I like to think of this as a bit of a proxy for the concentration of services across the provinces, but it's just one kind of service, and really want to recognize that there are a lot of others as well. But you'll notice that there is not an equal distribution of these services across the 4 Western provinces. In particular, Saskatchewan and Manitoba really are not at the same place as British Columbia or Alberta in terms of the scope of services or the coverage of services that are being offered. And that's in part because in previous years, the need was potentially less extreme. But as we saw from the data, that need is absolutely there across all 4 provinces. I'd also add that in Edmonton and Calgary, there have been recent announcements of closures to their supervised consumption sites by the provincial government. And so that map is also changing. On top of supervised consumption, there are a lot of innovations that have happened in this sphere that in 2019, we were thinking, okay, we're starting to make a little bit of progress here. That includes the distribution of naloxone that can reverse the effects of an overdose, innovative sort of treatment regimens and guidelines that were developed in BC, but then adopted nationally for using different approaches to the treatment of opioid use disorder. And what you see in the bottom right-hand corner is a drug testing machine. And so there's also the ability for people to have a little bit more information about what is in the drugs that they're using. During COVID-19, there were some responses that I would argue were critically important, the Canada Emergency Response Benefit being one of them. And there have been politicians that have pointed to the CERB as being responsible for the opioid surge and the overdose surge. One of the things that I would say is that I'm currently looking at that data with the team, and we aren't really seeing evidence that the CERB was responsible for that overdose surge. And so we should not be pointing at the money that people need in order to support their well-being. We should be pointing at the drugs that are poisoning them. There have been other measures that have been undertaken by advocacy organizations, by community. There have been sort of depenalization efforts at the federal government. And at the bottom, and I'll speak to this a little bit more in a second, what are known as the risk mitigation guidelines in BC, which is a first step towards providing a safe supply. But one of the things that we know is that it's been insufficient in terms of a response, it's been uneven, and it's been highly politicized. And so in BC, we are at a place where the provincial government is proposing the decriminalization of small amounts of drugs for possession and personal use. While in Alberta, we are seeing the closure of harm reduction services. In Saskatchewan, we're seeing sort of a mixed response where we're seeing a relaxing of COVID guidelines, of sort of mask requirements. They'll be the first province in the country to relax their mask requirements, alongside regional or municipal efforts to support harm reduction. And again, in Manitoba, very difficult to find a lot of public information about the scope of the response, about what is happening on the ground in Manitoba. I'm going to speak for a moment about decriminalization and safe supply, in part because these two initiatives have started to take up a lot of bandwidth in the media and in the public imagination about what our response should be. And there is a lot of potential for what decriminalization and safe supply could bring. But of course, the challenge is often in implementation, and the devil's a bit in the details here. I'm going to talk about each in turn. First, the safe supply guidelines were developed really, really quickly. And I think if the people who were at the heart of that development, if they had them to do over again, they might have done them a little bit differently. It is strictly a medical model. And while there have been non-medical models such as heroin compassion clubs move forward, the shift that's required to understand how to implement safe supply is really challenging, because it is a fundamentally different approach to illicit drugs than what we've worked with for the last 150 years, essentially. And what we know is that there have been a lot of barriers identified to the rollout of safe supply and alternative distribution programs, that the rollout was particularly bumpy, and that new efforts such as having vending machines, the federal government in the last budget actually included $3.5 million to support the distribution of opioid vending machines across the country. It's a really challenging thing to figure out how to do this in effective ways, how to reach people outside of urban centers, et cetera. And so there's a real challenge in how to roll all of this out. Similarly, with decriminalization, the idea here is that you start to decriminalize people so that they are less stigmatized, more likely to seek help, et cetera. And what you're seeing is a screenshot of the submission that the City of Vancouver made to Health Canada in the last couple of weeks, asking for certain amounts of drugs to be decriminalized, asking for an exemption to Section 56 of the Controlled Drugs and Substances Act to allow for personal possession. The challenge, of course, with what has happened with decriminalization is that it has been absolutely panned by advocates and scholars, myself included. And so in efforts to make this evidence-based, there were a group of scholars at the BC Centre on Substance Use who provided data to the city and made recommendations around what thresholds would be appropriate. And the decision that was made did not reflect the data, it did not reflect the recommendations, and the decision was made without consultation with people who have lived experience. And so because of that, and because the decision was predominantly driven by the Vancouver Police Department, what we're looking at now is a proposed model that has the potential to produce more harm rather than less. And you can see the quote there, the Prime Minister saying decriminalization of drugs is not a silver bullet for the overdose crisis. Absolutely, it is not. The decriminalization will do absolutely nothing to affect the toxicity of the drug supply that we know is at the heart of the problem. And so it is, again, something that in its implementation is gearing up for a really challenging run. So what I would offer as a potential alternative, or actually, I don't want to frame it as an alternative, I'd say as a complementary approach, is to think about how to prevent fatal and non-fatal drug poisoning to begin with. And in order to do that, we need to be thinking about how drug use intersects with socioeconomic conditions. And I'm conscious of time, so I'm not going to go too far into this, but really just want to say that we know that there is a really close relationship between people's material security, how they make their income, and their drug use behavior and drug-related outcomes. And in research that I've been conducting over the last 15 years, we've really understood how people who use drugs have lower labor market outcomes or suboptimal labor market outcomes, but that there are health impacts linked to the suboptimal labor market outcomes independently of their substance use patterns. And part of that is because people who are excluded from the labor market rely on high-risk income generation that produces more health harm. And so on top of all of that, my team has looked at the relationship between socioeconomic marginalization and overdose. And what we found is that the research in this area is really lacking. There's very little that explicitly focuses on that relationship. But among the research that does exist, we see that it is as you would expect it to be. People who have poor living conditions have higher likelihood of opioid-related overdose. And so we know that this is a potential area for intervention that has really been underemphasized in the public imagination, in media, by research, et cetera. I'd also ask people to start thinking about how drug poisoning intersects with social and economic policy. And what you're looking at here is a graph that shows the average number of deaths per day by Income Assistance Week. And so what that means is that the lighter area at the bottom are the average deaths per day in British Columbia over the last 4.5 years on non-payment weeks, on weeks where people were not paid their income assistance. And the dark blue above that is the additional average number of deaths per day that we see during income assistance payment weeks. And we know that income assistance payments are critically important in mitigating the harms from poverty that people who use drugs experience. But we also know that synchronizing those payments magnifies individual and social signals for increased use that puts people at elevated risk for drug poisoning. And so in order to see if we could do something about that, over the last several years, I've conducted an experiment that looks at what happens when you desynchronize people's payments and pay them in smaller, more frequent amounts. And it is a complex thing to do first it's complex to implement, but the results are also really complex in that our study participants decreased their drug use around payment days, both their individual payment days and the government payment day, by a significant amount. But being separated out from the rest of the system exposed them to other harms. And so we're currently working with data right now that hasn't yet been published, but what we're seeing is increases in other harms. So we had the desired effect on drug use, but what we're seeing is that there are other harms that increased because people were separated out from that synchronized system. And so I say all of this to say that it's important to be ready for unexpected impacts, because our reforms never function exactly the way as we envision them. And so I'm going to close now with 3 key points and 2 imperatives that I would like to pass along to people who are working in the philanthropic community and the community sector and the caring economy, as Margaret so eloquently talked about in her talk. The first is that we need to be thinking upstream and midstream. We need to be thinking about the role of social conditions in mental health and drug poisoning risk. We know that community-based health and social services can have a large and meaningful impact. And I, to anyone who will listen, am talking about how social policy is health policy and social policy is drug policy. We really need to be thinking about the conditions that put people at risk. And so I think there's a significant role for the philanthropic community to play. I know one of your hub's projects is really focused on linking with the United Way and the services that the United supports. I also think we should be thinking about bricks and walls. There is no single silver bullet solution. Harm reduction doesn't get us there. Decriminalization doesn't get us there. Recovery and abstinence-based treatment doesn't get us there. Safe supply doesn't get us there. Yeah. People are individuals and have varied responses, and it's really important to think through what is going to work in a particular circumstance. And so there is a need for mutually supportive intervention across community, health, and government organizations. Third, I think it's really important not to wait for government, but to not let government off the hook. So, for example, this story came out in Manitoba last week, where the chief administrative officer in Winnipeg essentially said supervised consumption sites can operate whether or not the province approves them. And we know that government often responds to things that they can see being effective. And that is what happened in Vancouver. Insight and other supervised consumption sites were built long before the federal government provided the exemption that allowed for its operation. Often we need to see community take initiative because they often have a better sense of the how of things rather than a government official sort of trying to conceptualize what it would look like on the ground. And so while there is need for huge public investment, we know that ideology and political expedience, as we've seen with supervised consumption site closures in Alberta and with the decriminalization process in British Columbia, it can really obscure evidence-based best practice across the political spectrum. So I'm going to offer two imperatives moving forward. The first is an imperative around equity-based responses. As COVID has made painfully clear for all of us, societal level shocks to our system don't affect everyone equally. We know this. What is less commonly understood is that interventions and innovations are also generally not accessed equally unless they're targeted really well. And so because they're not accessed equally, they can counterintuitively increase rather than decrease inequality, because the people who need the services most are the ones that experience the most barriers in trying to access them. The third thing to remember is that equity-based responses are context and population specific. And so they need to be accommodating social identity, social position, and geographic and political location in all cases in order to be effective. And I put a picture of the urban-rural divide there because I think that is something in Canada that we don't put enough emphasis on. The degree to which people living in rural communities have access to the services that people living in urban spaces, that divide is just, it is a really important gap that is going to have severe consequences moving forward. The last imperative that I want to add is that it is absolutely crucial to have the meaningful involvement of people with lived and living experience in the interventions that are put forward. They have knowledge about how things will play out so much more and at such a much more advanced level and in a real-time way. And so incorporating their wisdom and their knowledge and their experiential their experience is just critically important. I am going to leave it there. I want to thank you for your attention and consideration. Look forward to questions, and I also wish you all the best of luck for a successful conference. Thanks very much.
Okay, well, I would like to begin by just letting everybody know that this session is about access to mental health in Western Canada. And it is my pleasure to introduce and welcome our wonderful presenters, Jamie Montesso and Jacqueline Nelligan. Jamie is a registered nurse and a member of the University of Regina's Faculty of Nursing. Jamie is also a founder and president of the Mental Health Professional Practice Group, and she sits on the board of the Schizophrenia Society of Saskatchewan. Jacqueline is an executive director of the Ladysmith Family and Friends organization in Vancouver Island. Jacqueline's organization supports some of the most vulnerable families in the region through its family resource programming. The organization provides access to health services, food security initiatives, and creates opportunities for social inclusion. So Jamie and Jacqueline, thank you for making the time to be with us today, for sharing your insights, for sharing your knowledge. Welcome to our conference. Jamie and Jacqueline will present for 15 minutes, and then we will break up in groups for the discussion portion of this session. Please know that only the presentations will be recorded. We will not be recording the discussion to allow for a more free-flowing and sincere conversation. So Jamie, I will pass the torch to you to tell us a little bit about your research.
Thank you. I'm just going to share my screen here. So good afternoon. My name is Jamie Montesso, and I'm a faculty member with the University of Regina Faculty of Nursing. And I'm also a doctoral student, and I'm going to be presenting kind of from that lens, from being a doctoral student and some of the research that I've been doing, as well as, I guess, a nurse educator and a step parent to two 13-year-old twin boys. Where I work and learn is situated on Treaty 4 and Treaty 6 lands, which is territories of the Cree, Saulteaux, Dakota, Lakota, Nakota, and homeland of the Métis Nation. And while there's diverse peoples on the lands today, they're incredibly vital, and some of the literature supports just how incredibly important nature and being outdoors is, specifically with this pandemic and with what parents were telling me. So there we go. So I'm going to talk a little bit about the background and the context, and kind of give you some numbers and stats. Then I'll just go, I won't bore you to death, but I'll go a little bit into some of the highlights of the findings and kind of why I decided to choose the topic I did. And then I'll also talk just briefly about the mental health professional practice group. And Jacqueline's gonna have a lot more to say about kind of some of the philanthropic community supports that could be potentially out there, or maybe we can kind of develop different ones for some of the folks in Saskatchewan. So just a bit about the context. I mean, these are just some of the numbers that I actually got from the CMHA. So 1/5 of Canadian youth will have a mental illness or signs and symptoms of a mental illness every year. 1/3 receive inadequate care or don't seek care at all. And 50%, and this is significant, 50% of people who look back retrospectively have had signs and symptoms of a mental disorder before even hitting adolescence, and 70% before adulthood. So that's kind of some of the reasons why my study focused on preteen children, so kind of between that 8 and 12 year range. We know that children who develop mental health struggles endure kind of, during these fundamental years, endure kind of long-lasting impacts, specifically when they aren't seeking care or care is not adequate for them. We also know that in Saskatchewan, we have, it's very spread out, as is most of Canada, and we don't have a number of resources and in the amount that we need to kind of address some of these issues currently. And I think our keynote speaker spoke to some of that earlier this morning. So when a child does develop a mental illness, there's a wide ranging functional impairments that do show substantial kind of staying power into adulthood. And so really starting early is pretty important, and looking at ways that we can build on people's mental health. And then also when it comes to having, you know, mental health challenges, addressing them as they pop up for sure. So when I went to do my study, one of the things I wanted to look at was what parents' perspectives, as a new parent, as someone who did develop mental illness in their preteen years, I kind of wanted to understand that context better, specifically coming into a family where there's already 2 8-year-old children that had gone through some pretty difficult times. So I wanted to look at all areas of kind of mental wellness and how I could be a part of contributing to their mental well-being. So I decided to conduct a constructivist grounded theory inquiry to really capture what parents' understandings of mental health was, as well as how they strategize and how they think about their children's mental health and overall well-being. Some of the concerns immediately came up were peer relationships, and worried about children specifically, you know, that they're maybe not engaging with their friends as much as parents remember engaging with their friends, you know, maybe being on technology more or not being in home more. Other things that came up were being overscheduled, so they didn't really have time to go and play, just be kids and play, always having something structured to do. Another concern was around technology and social media, and that was a big one for parents. And I think some of that might be that, you know, Gen X and for older millennials like myself, we didn't necessarily grow up in a digital world where we would be online or interacting that way. We'd always be, you know, going down the block to our friend's house. Another thing was accessing care, and that was discussed a bit this morning and kind of one of our big overarching topics of the conference. And parents often discussed noticing that their children needed help, and then kind of gave us some stories about when and what they did and how it kind of worked out for them. So some of the things that they said is, why would you watch someone play? Like, go outside and play. And if anyone has children, middle age, actually children right across the board, I'm sure you've seen them watch YouTube where they're watching somebody say build a Lego tower instead of playing. So parents were expressing frustration with that. Another big one is, as you can see, Grace, it says it's not public, right? It's private. So there was numerous stories about trying to access care and the lengthy wait lists, as we know. Also things that I didn't consider, but I'm sure a lot of you might have already considered them, would be around, you know, not having access to care. So one of the families that I was speaking with, their children had, one of their children had specific, pretty significant mental health needs, and it would take them an hour and a half both ways driving once a week for one appointment, same thing for another appointment. And the cost even just to have the care was $140 a visit, which it can get quite expensive. So it wasn't only the fact that we don't have enough mental health professionals, or that, you know, people are accessing them at greater numbers. It was also just the cost. And I think that's something that is a challenge for many people. And then the other one, Mary had said, I worry with COVID now. She had trouble with making friends before, but this was at the very outset of COVID when I spoke with Mary. And I can only imagine now what the barriers with people being, I mean, now we've had multiple bouts across all of Western Canada, all of Canada, of schools shutting down and of people being further isolated. And so these were kind of some of the things that came up. And there's many more, but to keep brief. One of the things that I wanted to do as part of my studies was looking at, I recall this morning, Lindsey Richardson had said there's no single bullet solution. So when talking with parents, I wanted to understand, you know, changing from a paradigm of pathogenesis to more of a salutogenic focus. And for those of you that might not know what kind of salutogenic thinking or that lens would be, it's a complementary approach to the pathogenic paradigm that is largely what our health system is built on. We often talk about mental health promotion, but it's really we're conflating the idea with prevention and kind of not as upstream thinking as perhaps we should be thinking. It's difficult to talk about it now because we are in a crisis with the COVID pandemic. So I don't want to make light of anybody's struggles or suggest that we should just think about self-care and it will be lovely. So some of what I'm going to say is keep that in mind. So accessing supports and stuff is obviously very important, and but it happens when people are more at a crisis point. So what I wanted to look at was how parents promote their children's mental well-being, despite whatever kind of end of the spectrum they're on, and we're all going to experience mental health challenges at some point. So where the pathogenic approach kind of to mental health care focuses on illness, disease, disorder, and kind of works to mitigate or lessen the risks or avoid them altogether. A salutogenic focus would emphasize moving people where they're at to better kind of mental wellness. Recognizing that life is stressor rich and we're all in a state of entropy, we're kind of looking at the mental health assets that we already have and how we can better utilize them. So a salutogenic approach to mental health or health promotion in general, Aaron Antonovsky is kind of he spearheaded everything. He's since passed. These are a couple of quotes, but the one is, how can we move this person wherever they are to greater health? So he did a lot of research on Holocaust females that survived the Holocaust and was wanting to know why some people kind of declined quite significantly and had post-traumatic stress, all those kind of things after the Holocaust, and why some women went on to lead healthy, happy lives. So that's kind of where some of this stemmed from. And that is one of, you know, there's been numerous other instances of great tragedy, and some people, why would some people kind of have that growth after it, and why others end up getting much sicker. So after looking at those kind of things, what parents said, so initially they were focusing on kind of some of the problems, and then looking at what are some of the things that are going well. You know, even children, some of the children in the study had mental health challenges for sure. Some were diagnosed, some were still waiting for care, some parents, so it was quite a mix. But they started to say things like this, how much the school's been influential, and schools really have started doing mindfulness, doing so many different things. They started talking about what they do around sleep, that some of the things around time, like how spending time with people, they wanted to have good people, raise good people. And so some of the things that kind of we built on from there is what can they do or where can they go? And a lot of parents didn't know where to go for reliable resources. So while some people knew that nature was very health promoting, and actually just in a recent study that a group did in Saskatchewan, that they found that going outside has been one of the biggest, had the biggest positive impact. I think it was 33% on, they were adults, but of adults during the COVID-19 pandemic. And so, and they found that connection, social isolation was one of the biggest detriments to mental health during this pandemic. So even looking at things, teaching or giving parents the tools, or how do parents come up with what they think is the best kind of way to care for their children or to promote their mental health. So these are just some of the constant things that came out. There's numerous others. But these are some of the things that, one of the big things that came up when parents were talking is that they are doing things by trial and error. And now with the pandemic, and you know, I'm sure it's even greater, where they're kind of learning as they go. And some parents have a good grasp on, you know, what they believe their children need, and others kind of really showed their worry and doubt in themselves. And so how can we, you know, build the skills of parents, kind of hone in on what their strengths are, and then translating that to children. One of the things that we developed, not as a result of that, but just prior to that, a group of us decided to start a mental health professional practice group with the help of the SRNA. And we were initially looking at, and this is pre-pandemic, again, early in 2019, we started looking at nurses' mental health, and we found that the literature was saying that it's, you know, there's a lot of burnout, caregiver stress, all of those types of things. So we started with that focus in mind. And I can type it into the chat later if anybody wants to check it out. But then we started to shift the focus and look at kind of more population mental health. And we've targeted different kind of areas, and kind of having a repository of information that hopefully could be helpful to someone. So that's kind of where we started, and we're still kind of developing it. So it's pretty bare bones. And as I'm the only web developer and I have no skills, so it is rudimentary, but we're hoping that we can kind of broaden it. And hopefully there's been so many resources that have now come since the COVID pandemic, and there has been a lot of focus on mental wellness. So this may not hold as much relevance, but certainly it's another tool that people can go to. I'm not sure why it's going backwards. And just some of the final thoughts, I think my time is up, is just that parents that I've spoken to across Saskatchewan are doing their best. They're stressed and struggling, some of them, specifically the ones I talked to during the beginning of the pandemic. But they have a lot of strengths and resources, and they really rely on the knowledge of within their community and others. So finding ways to, you know, prior to help seeking, if there's anything that we can do to, or anything that it would be helpful even to have in physicians' offices, because we know a lot of times that's where people are accessing care. So I'm really hoping that while we're chatting and we think about, you know, all the preventative things and all those kind of important things, looking at some of the things that are working, maybe how we can build on some of those good things that are happening. And then looking at other things, what supports are needed and what lessons has COVID-19 provided us. And I'm not sure if there is discussion room topics already, but these are just some ideas. And I don't know why it keeps going back to that slide. But anyways, I just wanted to thank everyone for giving me the time to present some of my ideas and thoughts. And yeah, I look forward to hearing the rest of the presenters. So thank you.
Thank you, Jamie, so much. You know, you talk about such an important topic, and just being a mom of 3 and having, you know, my middle son is 6 years old, my daughter is 10, and a little guy 3 years old. I can see how the pandemic, just experiencing, you know, as a parent on a daily basis where, you know, my daughter will say, well, I'm not taking masks for the rest of my elementary school years because, you know, of the worry and the anxiety that creates. Whereas, you know, someone else might feel like, okay, well, you know, I don't want to go back to school because of all these germs and what's going to happen, right? So it is such, like, it's just such an important topic that you're raising. And I'm so glad that you are speaking openly about this, because as parents, and I'm starting to blush, I feel myself, because as parents, caregivers, we tend to, you know, feel nervous raising those things, right? And so I really do appreciate kind of the openness and some of the lessons that you've learned as you were conducting your research. So thank you. And now we're moving to Jacqueline, and we're so thrilled that we can, you know, as we mentioned in the beginning of the conference, and kind of to facilitate, we have an academic researcher, and we also have a person from the community. And I'm so glad that we're able to have kind of this mix that we can, and that they're, you know, can be talking to each other in a way. And so thank you, Jacqueline, for making the time to be with us and to bring that on the ground perspective, which is so crucial to, you know, to us learning about what is really happening, not just from academic research, but also what's happening kind of on the ground, on where you are. So please, if you have some thoughts to share, we'd love to hear.
Oh, thank you very much for having me. I live in Ladysmith on Vancouver Island in British Columbia, and I am grateful to be able to share this land with the Stamanis people. Now more than ever, creating this partnership and just the generosity that they extend to myself and to our organization and nonprofit means so much to myself and to the whole community. So Ladysmith Family and Friends, we're a nonprofit family resource program supporting about 500 families in the community in the region. And when we say supporting the most vulnerable of families, honestly, I think every family is a very vulnerable family. For myself, I started in this organization as a participant 26 years ago. We just celebrated our 25th anniversary here as an organization. And what I needed then is which was a safe place for me and my twins that were 2 years old at the time, and I was pregnant with number 3, and my husband at the time was a full-time student. We did not have resources, and financially things were really tricky. And I was fortunate enough to connect with a few other women and 2 dads that wanted to form a group, an organization to just meet up and have almost like that community kitchen, community living room feel. And it has grown. So I started off as a participant, then I joined the board, and 6 years later I was hired as the coordinator and then turned executive director. And the organization has grown, shifted, and changed. I have a background of community development, starting as a child living in a community, actually, with 3 other families, and having that feel that everyone had something positive to give, and also an opportunity to receive, so that that giving and taking runs very strongly in me. And it is what over this past year has allowed us as an organization to keep pivoting and changing and shifting and meeting the needs of families and children. In Ladysmith, children are their social determinants of health. They're suffering right now. So 34% of kids are entering school age and not feeling or not having all the skills that they need in order to survive and thrive and have bright futures. So as an organization, we really believe in early intervention and prevention. And so that has been around creating this community space where we meet those needs of children, families, caregivers, and we also create opportunities for the community to get connected. So whether that's the resource providers coming in, Island Health, the dietitian, the mental wellness, mental health specialists, speech and language pathology, or maybe it's the librarian or someone from Parks and Rec that's coming in and teaching physical literacy. We continue to find ways for community engagement and community growth and community connection. Fortunately, we have great support. So we really believe that there's no wrong door, no wrong way to connect in community, as long as we can help be that resource to act as a gateway to services to other resources, or have other resources come in and connect. So pre-COVID, our day would look like coming into a community hall. There might be 100 or 120 people attending. We would have the French toast station set up. The local bakery would be donating bread. The local farmer would donate eggs. We would have participants bring in a piece of fruit, and we would chop over the cutting boards and have those really important conversations and make those really deep connections. There'd be a clothing exchange. There'd be the Brio train station, and we would have different providers coming in. One of them might be a yoga instructor who 3 days a week would do yoga with families, and really super engaging and meeting the needs of people where they were at. All of this is possible because we have a board of directors who works tirelessly alongside. They act as a governance board, but they have created this foundation for the Family Resource Program to be able to be really able to be fluid in community connections with all the different resources that are in the community. Also connecting with or allowing like the different funders to see how can they help. So for example, we have a local carpenter who yesterday dropped off 2 big garden beds. And so we have fresh garden beds that now children during COVID with their parents, we will be able to start to open up and connect with them on a really natural, getting your hands in the dirt level. That's so important for creating those opportunities for connection and engagement. We're noticing that during COVID, many families are feeling very nervous about getting outside at all. We have one family who was pretty much wanting to stay recluse for about the first 7 months. So instead of being able to connect the way we had been doing in the resource program, we set up an outside driveway so families could meet up that way, or families couldn't meet up, but they could sign up to come and access meal in a bag or have a one-on-one conversation with staff in a safe way and really talk about what they were experiencing and what their challenges were. We were able to maintain our relationship with Vancouver Island University, and we're able to have third and fourth year nursing students continue to do community practice practicums within the organization, but from afar. And so one of the opportunities that they took charge of and ran with was creating a resource guide that showed and highlighted all the resources that were still available to families. So even though the resources couldn't be coming to our family resource drop-in program, families were able to know that there was still resources available. They could still access mental health. They could still access a dietitian. They could still access different ways that the community was still there for them and gave them a lot of reassurance. Again, pre-COVID, we would have anywhere from 80 to about 100 senior volunteers. Some of them would be volunteering right in the program, creating crafts for children to do, play-based learning activities. And once COVID hit, those opportunities weren't there. And actually seniors ended up being some of the people that really needed our support. And so we were able to meet them in their driveways, bring them a jar of all the ingredients for them to make oatmeal, or bring them supplies that they could, again, continue to make craft packages up that we could send out to families. With the organization being the way it is, we're always looking for ways to be strength-based, to find opportunities for each of our staff to show up and shine in their own unique ways, and also to role model that for our participants. So having lots of those conversations, like Jamie was talking about earlier in the last segment, like asking parents, what kind of activities did you do as a child? What really lit you up? And being able to invite them to share those activities now with their children. And as many of us will know, getting out into nature has been a way of really fostering that connection to the land, that connection to ourselves, learning about grounding, about looking up, stopping, breathing, to self-regulate. What else can I tell you about our family resource program? Right now we have 7 staff, and each one is, again, showing up and finding a way to connect in community in a way that's meaningful to them. And what I'm finding as a leader of this organization is the more that I can role model, and I can encourage my staff to role model, just showing up authentically and having those really congruent conversations with self and with each other as a team, and with our volunteers and with our parents. We're noticing the ripple effects of those kind of really congruent connecting moments, to let people know they're not alone. We are all in this together. It looks different for each and every one of us. And seeing ourselves as like a piece of a puzzle, when we all show up authentically as ourselves, we can start to fit together in a way that we're able to both support and receive support from each other. That might be looking very different for many, many people, but it's working. So our day-to-day, we're not connecting in a room of 120 people. We're now connecting by, we actually had to move out of the hall that we had been connecting with. That turned into an immunization station. And so we were invited to move into a school that no longer was running. And we could have had like a scarcity mentality around that, like the sky is falling, but instead, just as we all have been encouraged and found that we've needed to do, we've found a new rhythm. We continue to find new ways of making this work. So the joyful part was we were able to have more of our seniors each have their own classroom. They could each develop their own packages or their own little ways of connecting with families. So we have every week we have 100 packages of produce that either families can sign up and come and do a pickup, or we will deliver fresh produce to seniors or families, and they can ask for it, or we can do surprise visits. We're also able to increase our partnerships with different food rescue organizations. And so we have a full pantry, and families, again, we don't have to come from a place of scarcity. There is abundance in community. And I kind of think of myself as a bit of a matchmaker in community, finding ways to connect the resources with those that could really benefit from the resource. And that ticks both boxes too. People want to give, people want to be part of a solution, and continuing to find ways to allow that to happen is super amazing. I have the greatest job in the world, and I feel so privileged to be able to support families. Yeah.
Coming in, that's great. Well, welcome everyone to this afternoon session, and welcome to those of you who are joining us for the first time. Welcome to those of you who are coming back to our conference. And we are, our event is the Place of Philanthropy and Community Mental Health. So we're really excited to see our speakers today and everybody in the audience. That is exciting. The session that we're going to have you listen to is entitled The Role of Philanthropy in Filling Governmental Gaps in Mental Health Supports. And I'm incredibly thankful, and we're so fortunate that Dara Parker from the Vancouver Foundation has kindly agreed to moderate this session. For those of you who might be a little bit tired of my voice, we'll have Dara freshen things up for us. So thank you, Dara, for being here today with us and for doing a bit of heavy lifting with us. For those of you who haven't met Dara, she's a nonprofit executive with over 20 years experience working in social purpose organizations. She's currently the Vice President of Grants and Community Initiatives at the Vancouver Foundation, where she leads a team of 17 individuals and is responsible for deploying 15 to 20 million in grants annually. And she also has just wonderful 2 puppies that have fabulous names that she has shared with us to keep her, happy and running at the end of the day. So Dara, I'm going to pass the torch to you to introduce our speakers and make some opening remarks.
Thank you so much. And you left a real teaser there. You said they have interesting names but didn't share them. So now I feel obliged to let the people know what they want to know. Yes, I do have 2 French bulldogs. The older brother is named Mr. Bumper, and Sir Waffles just joined us 4.5 months ago and is just a reign of terror over the house. So we'll share pictures if there's time. Thank you so much for having me today. I wanted to start by sharing that I'm calling in today from the unceded territories of the Syilx Okanagan people. I'm really grateful to be a guest on these territories. This is a new home for me, and just wanted to take a moment to reflect on what it means to be an uninvited guest, and especially moving to a region where there have been horrific headlines over the last week, and just reconnecting to my commitment to understand what it means to be that uninvited guest, and my relationship with First Nations people across this country we call Canada. I also have the privilege of serving as that Vice President of Grants and Community Initiatives, as I was introduced, at the Vancouver Foundation. We are the Vancouver Foundation. Our mandate is to serve across BC. And as a community foundation, it's critical to us that we take direction on how we do our work from communities. In fact, our tagline is community inspired. And that's because we believe that local knowledge is incredibly powerful, and that those closest to the issues that they're addressing should be leading the response to the issues. That proximity is important, and not just important, but critical. And so I'm excited that today we're going to hear from some of the folks who are doing just that. I'm delighted to be able to highlight some of the incredible community leaders who have stepped in where they've identified government gaps in services. And so we've got 4 different groups we're going to hear from today. And I want to start by introducing you to, and I have not double checked on pronunciation of names, so I'll invite our guests to correct me if I get it wrong. But our first group is Katrina Verschoor, Kim Rockins, and Sandy McCrate, who are going to share more information about their program, Increasing Recreation Involving Seniors, that they initiated last fall with the Castlegar Community Response Network.
Hi, everyone. My name is Kim Rockins, and I'm a nursing instructor at Selkirk College in Castlegar. I'm also a dog mama, and my dog's name is Hank. It's not quite as cool as Waffles, but it's not bad. I'll just get our presentation up. All right. So I'd also like to start with a land acknowledgement. I'd like to show deep gratitude to the First Nations of the West Kootenay and Boundary regions upon which I reside, and all our research that I'm going to tell you about took place. So that's the Sinixt, the Syilx, the Katunaha, and the Secwepemc peoples. So today I'll be presenting on a research study which my colleagues Katrina and Sandy and I did on the impact COVID-19 was having on community dwelling seniors in our area. So both Katrina and Sandy are here today, and they'll be contributing to the presentation and answering questions and conversing afterwards as well. Katrina is also a nursing faculty member at Selkirk, while Sandy is the founder of an impactful community-based program that supports seniors' well-being. And it's called IRIS, or Increasing Recreation Involving Seniors. So recently, to do this research, we've been partnering closely with Sandy to find out what the community needs were. So when COVID was deemed a pandemic, I was very pregnant and teaching my nursing students from a desktop computer, and I felt helpless. I knew that, you know, countless grandparents were struggling with the fact that they couldn't hug their grandchildren, and about to have a baby myself, and my parents and in-laws weren't going to be able to meet the baby. And I started talking to one of my colleagues about what I could do and how I could do more. And I was just finishing my master's program as well. So my colleague said, well, you should call Sandy. And so our research study was born from that phone call with Sandy. And I pitched a bunch of ideas to Sandy. And eventually she kind of slowed me down and tempered my excitement a little bit and said, maybe we should ask seniors what they need. And so that was a big lesson number 1 for me in developing a health initiative, was to do your homework and listen first, because all your work can be amiss if you are thinking your ideas are right and you haven't talked to your community. So it sounds like that's a lot of what the Vancouver Foundation does too. So I should have read your slogan before I headed down this path. So as I reviewed the literature on how seniors were coping across Canada and the globe, it became clear that more research on rural populations and corresponding supports were needed. Again, I was just finishing up my master's and looking for a capstone project. So this was a really good fit that I could try my hand in research. I hadn't done anything like this before. And Katrina, my colleague, had a little more experience in this area and keenly jumped aboard. And we also hired a couple research interns. One was a nursing student and another had just finished her business degree. So we had a really great team it was a diverse team for sure. And it was really nice getting students involved as well, because the fresh ideas from students that hadn't already worked as nurses was really great. So at the time, due to the recent nature of the pandemic, little research had been done eliciting data on the impact COVID was having on the health and wellness of seniors from their perspective. I read a lot that was written by physicians on their perspectives on the impact COVID was having on their patients, but there were very little firsthand accounts, especially from community dwelling seniors, on how COVID was impacting them. And also, many of the studies that have been done were surveys that were mostly closed-ended questions. So our study was somewhat unique in that it used many open-ended questions and it allowed for seniors' voices to really be heard. So who better to guide the communities and practitioners on how to best support seniors than seniors themselves? So today I'll be explaining our research findings and sharing how we've used our data to develop some health initiatives in our rural community. And then Katrina will be concluding, with the main benefits and takeaways from our work. And then after the presentation, Sandy will be available and speak a little bit about her nonprofit and how it's supporting research and these connections with students and these intergenerational relationships with seniors. Okay. So the objectives of our study were to explore how seniors believe their mental and physical health has been impacted by COVID, and also elicit ideas from seniors on what they feel would be some great supports during the pandemic. So we started this survey, we ran it over last summer. So the second wave hadn't hit yet. And spring, summer was when the guidelines, the public health guidelines loosened a little bit. So it was really nice because we could implement some of our health initiatives and then the guidelines tightened up again. So we've had to be really innovative and flexible, and our ideas for health initiatives have shifted around a lot. But it was really great to get seniors' take on it and what supports they thought would be useful, and then try and figure out how to make it happen in a safe fashion. So to gather this information, we recruited participants through IRIS, Sandy's Sandy's organization. We also advertised on local radio and newspaper, and the survey was offered online via SurveyMonkey and on paper and by telephone interviews. Sandy and her team of volunteers have been delivering lunches to seniors in Castlegar throughout the pandemic. And the lunches are accompanied with a newsletter. So we slid our survey in there. And so that was a really great way to connect with seniors without putting them in danger in any way from close contact. So at that time, we didn't know too much about COVID. So we were trying to figure out a safe way to get the survey out there if people couldn't get online. So most of our participants were females between the ages of 65 and 74 who lived within the city of Castlegar. All right. So I'll just get into our results a little bit here. So prior to the pandemic, 15% of our respondents stated they had felt moderate to severely lonely. And then this increased drastically to 65% after the pandemic began. So as you can see from the results on the right, majority of the seniors we surveyed felt their mental and physical health had been negatively impacted by the pandemic. I also want to add here that there were some responses which indicated the pandemic had had positive effects on people's mental and physical health. They were sort of silver linings that the research team went, oh, I didn't think of that, and how COVID could impact someone that way. For example, some stated they were getting more exercise as they could no longer have people coming into their homes to support with cleaning or yard work and things like that. So there were a few things that we hadn't thought of, and we really appreciated how many of our respondents had found this silver lining and They were great stories to share with other seniors because they promoted hope and showed resilience and things. So I'll get more to that later. Okay, so when we themed our data, we came up with some prominent themes, both under the mental health and the physical health realm, which we know are very interrelated. So when asked about the impact of COVID on their mental health, social isolation was one of the main themes, present in 33% of our responses. It was mostly related to the inability to see friends and family or make social connection with others. I have a quote here. One senior stated, "It's stressful to have lost my social outlet, which was grocery shopping for myself. I'm totally alone most of the time. No family here. Friends are old too." Another prominent theme was fear and anxiety in 19% of our responses. And of these responses, 70% were related to transmission of the virus, both to self and others. Again, we have to kind of shift our thinking back to when we ran this survey and we didn't know as much about COVID as we do now. So I suspect that would be different if we surveyed again. Another theme was depression, present in 25% of our responses. One senior stated, "I cry more often. I feel sorry for myself more. Sometimes I feel ungrounded mentally, and I do better when I get to see people." So in regards to physical health, the main themes were exacerbated health issues, decreased activity due to less opportunities to safely recreate, and changes to access of healthcare services. And those were our most common themes here. One senior stated that it's hard to get up and get going when there's no place to go. Consequent inactivity has caused physical deterioration. So stiffer joints, more achy, more tired. So services such as massage and physio and exercise classes were totally canceled in the beginning. So that was when we were running our survey. So again, I suspect this, as people pivoted online, this might be a bit different, but it was definitely a huge barrier to seniors' physical health in our area. And the last theme that we noticed was present in many of the responses to questions related to physical and mental health. And our research team, as we were theming it, we kind of, hey, did you guys notice this? There's a lot of talk about these things that people miss, and they're grieving these loss in, routines and rituals, changes in employment. They're not able to volunteer where they used to anymore, and grieving the loss of social connections and loved ones and relationships. And it percolated throughout our survey. So we felt the prominence of this theme might be related to age, although we all agreed on the team that we were feeling this grief as well. But we thought that from talking to many seniors that perhaps time has a different meaning to us as we age, and seniors might be feeling this grief more profoundly than other age groups, because they might feel they're being robbed of their quality of life and routines as they're nearing the end of their lives. One response that clearly illustrated this theme was, "I feel dispirited. There's little to distract from the constant barrage of gloomy news, and with little hope that there will be a return to the norm in my lifetime." So I think it's easier as a younger individual to say, hey, I'm going to see the end of this. But perhaps with age, it's harder to see that light at the end of the tunnel, although we are seeing a lot of positive coming out of all these vaccinations. So it's great. All right, and some of the suggestions that seniors had for us that they felt would be helpful moving forward were more opportunities to safely recreate and socialize, such as walking groups was recommended by lots of the seniors we surveyed. They also called for more clear and current information on COVID and the associated public health guidelines. So if we can think back, it was changing a lot at the beginning of the pandemic. So we designed a health initiative with the students to sort of address this coming up in our survey so often. So what did we do with our results? Well, we designed a couple amazing health initiatives with some nursing students that we partnered with. In addressing the need for safe social connection and exercise, the nursing students partnered with IRIS and started an outdoor walking group So you can see them all masked up here. And they did run it inside one day. And then winter started to hit, and so it wasn't possible. And then things tightened up with the second wave. So that they ran it for quite a few weeks, and we got lots of really positive feedback from the seniors that attended. The students also organized a COVID info session for seniors to address this need for more current and clear information on what the public health guidelines were and sort of what was happening with COVID in our community. So the seniors got to attend a coffee group, all safely distanced inside, and we just had a limited number of seniors attend. And they learned about COVID regulations, proper ways to put on a mask and don and doff, as well as sharing their stories of the impact COVID was having on their lives and sharing those stories of resilience, those silver linings. And a lot of the seniors just couldn't say enough about how nice it was to sort of just share how it was going with some other seniors. So unfortunately, when things tightened up again, we couldn't do any more of these, but it was really great to see how this could work again later, maybe in an outdoor setting or running it again. So another part of this, after we realized how great it was to share these stories of resilience, the nursing students helped with the IRIS newsletter that goes out with the lunches every couple weeks. So what they did was they'd call a different senior each week on the phone, and it was totally voluntary, and they'd chat to them about the impact COVID was having on their lives and some coping mechanisms that they'd found helpful. And then they wrote a little column about that senior with their permission in the newsletter. So that was a really great way of sharing things around and fostering that social connection, both between seniors in our community and between the seniors and the students. So lots of really great intergenerational relationships came from all these interviews that were happening over the phone. And the last initiative that we just wrapped up recently, we had student volunteers from various disciplines. So nursing, we have a rural pre-medicine program here at Selkirk, as well as social work students. And we had them call and have phone conversations with seniors once a week. So they'd chat for, half an hour to an hour once a week. And it wasn't focused on COVID, but about this, whatever they wanted to talk about, really. And we had some guiding questions. And so the senior could share a little bit about their lives, whatever they were comfortable with. And then they had an option to make a photo storybook with their senior partner in the end. So the books are just being put together now for some of the seniors, and we've had a focus group with the students and done some follow-up phone calls with seniors. And it seems that it was really, really a great initiative, and both the students and the seniors really enjoyed their time together, and some of the relationships seem like they're going to be a long-lasting relationship. So it's really great to see.
It makes me want to travel to Castlegar when we can do things like traveling again. I think it's in our future. Up next, it's my pleasure to introduce Mona Cooley, probably, who is looking for help for her family when they learned that their daughter had bipolar disorder. Her daughter was getting the medical help she needed, however, there were no programs available for the family. As a family, they were left to fend for themselves, which led her to found the Cool Family Services to fill this gap in services and help families learn to engage in healthy, honest conversations about difficult situations. Mona, I'm going to pass it over to you.
Our daughter was leaving on the weekend vacation. It was finishing her third year in nursing. And she decided to go out, and they left Friday night. She came back Sunday. And by the end of the week, she had the cure for AIDS, and she was going to be an Olympic skater and could predict the future. She had a closer relationship with God, and she was dancing and singing fervently throughout the evening in her room. She was also very frustrated with the family when we didn't connect with all her ideas of what she thought she could do and didn't support her. And she thought, I'm going to escape. So she bolted out of the door of the house. My son, our two daughters ran after her and hauled her down onto the ground in the front yard. And then we took her to the hospital. She relinquished. But while we were taking her to the Foothills Hospital, she laughed all the way. This is God's plan for me. I'm to be inside the hospital. I can fix all the problems. Can you imagine what it was like to have that happen? And it just happened, and had no idea. And it was hard to believe. I'm thinking, taking her to the hospital, would they even believe us? She was diagnosed with bipolar disorder that evening. Now, that is not common. In most cases, not always are they diagnosed that quickly. But I do want to tell you where she is today. She was 22 at the time when she had this psychotic episode. She's 48. She has 3 beautiful children. They are 12 to 17. And she's married to a wonderful man, and they're celebrating their 25th anniversary this month on June 29th. And she completed her MBA and now contracted by CMHA Calgary. I wanted to share our beginning and shock of what was ahead of us. In 1995, Candace was getting the help, but there was no help for us, the family. This is the gap. I was so frustrated. I was asking the doctors, where can we as a family get help? They didn't know, didn't have a clue. So I was complaining to a good friend about this, and she looked me straight in the eye. She says, Mona, do something about it rather than complain. Mission was set. I made it my mission that I was going to help families. Family plays a critical role in creating an environment for change. And here's where the gap is. It's understanding how to best equip families. There's lots of complexities with families. And then engaging them into honest, healthy conversations and how to effectively support a loved one. We were fortunate as a family. That night after we had to put her into the hospital and going home and trying to regain our emotions and everything else, I had to make sure that she had completed her 3rd year and all the paperwork was done, because this was in May as she finished her 3rd year. I phoned up to the university, and that professor, I told her what had happened and what she was diagnosed. And she says, you need to phone this lady at Canadian Mental Health Association. I gladly did. When I phoned her, I knew that herself was bipolar and her children. And when I told her our story, she says, take care of yourself. I said, what? You gotta be kidding. Take care of myself and all this chaos and everything going on. She says, I'll only say this once to you. She says, you either take care of yourself or you'll go down with her, and then you're no good to her. As upset as I was at that statement, I realized that she had a point. And so I took it very seriously. And that made a huge difference. Then the other part was, this lady took our children under her wing. And it was her boyfriend, now husband, and our other 3 children, and had a conversation with them. And my husband had to go to Northern Alberta at the time of this incident. So putting his daughter in the hospital Saturday night and leaving Sunday, he felt like he was closing the door on her. And he was very emotional about this whole process of what was happening. When he returned 10 days later to Calgary, we met with this lady again. We were very fortunate that this lady, within 12 hours, we had somebody that connected with us, understood, got what we were going through. It made a huge impact on our family. Even though our family was floundering and could be overwhelmed at times, and you wondered, what's the future of our loved one's future? Is it in jeopardy? We were left to figure out, for the most part, all the challenges that we were faced with and how to help our loved one. It was sinking like a Titanic, leaving the loved one feeling alone in the ocean, trying to stay afloat. As one quote that I had from an individual from Harmonized Health, another organization that I'm part of, operations team member said, "The least healthy member of the family is driving the family bus. And when they do well, the family does well. And when they don't do well, they will take the family down the rabbit holes with them," which is very true. And that's exactly what this lady was saying. If I hadn't taken care of myself, I couldn't be much help to her. Family plays a critical role in creating an environment of change. You remember that lady that told me I better do something about it instead of complaining? Well, I have. And this is where philanthropy, the part that I can play, is closing the gap for families, bit by bit. I focused on making a difference for families. And this was after a time of us getting ourselves in a better place of working through some of our own challenges. But this has been and will be my purpose from this point, from 1995 and onward. Here's one of we shared lived experiences. So we lived through that trial and error. We got through it. And the CMHA staff, I went to them and said, we need a family program. But they asked me first, how was it that I was progressing? Our family was making strides. Well, there's one thing this mother had to learn, was to listen. Yeah, I was a heck of a good fixer and trying to control the situation, but it definitely wasn't working. When my daughter said to me one day, "Mom, you don't listen, and by the way, quit telling me what to do and help me problem solve," I stopped. I thought I was listening. No, I was busy. Every time she had a challenge, I was busy telling her how to fix it. And that isn't what she wanted. She just wanted to be heard and understood. Now, the other side of the coin is she was blaming me every day for the problem that she was dealing with her bipolar. And for the first 10 days, I was tiptoeing. I didn't know what to do. I didn't know how to go about things. All of that was very challenging. But I decided one day after I went home after being blamed again, I cried. I had my pity party. I did all of that and decided I'm not going to listen to this anymore. So I decided what I would do if when I went up the next day, she would start. And she did start to blame me. And I said, stop. No more blaming. Neither you or me, because it's not going to pull us forward to where we need to be. And if you decide that you want to blame me today, I'm going to go home and I'll come back tomorrow. Now, you may all feel that's pretty strong, but it was that boundary. As much as it was hard to say, it was what was needed, because blaming does not solve anything. And then, and through that, we respected. I started listening, shut my mouth. and listened and started to reflect back what I heard and understood. Then asked her, there was 2 questions I asked her. What is working that what we're doing? And she appreciated that we were listening now. And then she would tell us what we were doing wrong. And that was, she was sick and tired of being told what to do. She just needed to vent and have those expressions done. These were the honest conversations that were happening. Our daughter, as well as myself, have done public speaking, telling our story. And I remember CMHA asking me if I would speak publicly when we were barely just getting through our stuff and we were progressing and they were launching a cookbook. And I decided, yes, I wanted to help. If our story can help anyone, I wanted to do it. And then I volunteered for CMHA, and any family that came in, they would put them over to me to have a chat with. And I could see how much of a difference it made. I remember what that difference felt like, and I wanted to give back the same. In 1996, I was leading the peer support groups at CMHA for the families. And I was there for most of 20 years. And what the deal was is people could drop in and we would have education and we would talk about subjects, and then we do a problem solving activity. And the rule that I had was, we can all complain about the system, but I said, yeah, you got 2 minutes to complain and then you got to go to work, because complaining about it didn't work for me. It was about what I was going to do different and figure out what we were going to do different as a family. But this one night they came in, and there was 15 of them that came in, and they were all saying the same thing that was a challenge for them. And I stopped the meeting and I said, write down the issue you have of where you're not feeling heard and understood, and I will do something with it. At the time when I said it, I didn't know for sure what I would do with it, but then it struck me. There was another incident showed up and I decided enough is enough. I phoned up to the Alberta Advocate Mental Health Advocacy, and I asked the person there, I needed to speak to somebody, and I would only take 15 minutes of their time. And that's what I did. That person listened to me. She heard what I was saying. And she said, Mona, I will get back to you in a week. And if I don't, you call me. I says, count on it. But she got back to me. And she put me in touch with Janet Schaaf here in Calgary. And I told her the same thing about, the challenges, and I had the list. She formed a committee. And the committee, we sat down and they asked me, they said, Mona, what do you want? We're here now to help. And I said, we need to have a brochure with some tips for families. We also need how the loved one can be part of that solution, and also the professionals, and how this group can be together and be supportive in a way that families, the loved one, and the professionals all can work. This was set out in 2015 of February. And when it was distributed, a brochure, Together We Are Better, October 15th, 2015. Again, I was listened, and somebody listened and heard me and paid attention to it. That makes a huge difference when you're feeling heard and understood. And this is what families are struggling with. Now, I've gone on further from there. As I mentioned, I have a company, Cool Family Solutions. When I was doing my sessions, outside of CMHA. At this time, CMHA were moving forward in different ways, and I was going in another direction, but we still have that good relationship. I decided that there was something more that needed to be done. And I decided to develop a 10-week program. Because what I was finding is individuals needed that consistency for that time in order to learn tools such as love, listen, understand, and validate. And it's a process. We just don't take a tool and think we're practicing. It's a process. And there need to be a process of time. Now, through all of this, there was one gal that came to the peer support when I was at CMHA. And she was a mom, and her daughter was 14. And she came to the group, and I was told, boy, she's going to be tough. Because she was referred by somebody, and I thought, okay. So when she came, and that one evening I asked her, I said, are you prepared to change? She said, yes, but I need to know how to. She was getting told to listen, but she didn't know how to listen. And it was listening to hearing what the daughter said and reflecting back, did I understand you to say this? And make sure that it was clear. This daughter had attempted suicide twice when she had landed at this group. It was 4 or 5 weeks later, she came to the group consistently. And she was very nervous. And I said, what's happening? I sensed something was very wrong. And she says, I'm nervous that my daughter's going to attempt again. So action was taken. Her husband got to the train station in time to grab his daughter, and she had the note in her hand. This same girl is 20 years old today. And what happened that night when the dad took her home to the mom had learned ways in order to have those conversations of how she felt if she had done this and be lost and hurt and everything. And the daughter says, really? I just thought you'd be better without me. She said, absolutely not. We need to work through this. We need to work through this and have conversations, to say what we feel and think and listen and hear. And these were things that she was doing. That was the beginning of change. And that same daughter now has just graduated. She wasn't even going to school. She was struggling. But she was also now has helped others through her challenges, with their challenges similar to her. Family plays a critical role in creating an environment of change when they know the tools to use and how to use them and how to approach difficult situations. It's getting to the root of really where they are. And it's lots of times it's fear and anxiety in themselves. And the loved one sees that anxiety in them, in our people that support. And it was helping them to work through that and come up with strategies of how to work through their difficult situations. Does this really work? That's always the question when you hear new programs or hear these programs. Does it really work? I have some testimonials for you. Because of this 10 weeks, I had another organization, Thumbs Up Foundation in Airdrie, who came to a session when I was opening the doors to my company. And they believed in this family concept. They piloted, and they have done, I'm on my 11th pilot. First of all, the Thumbs Up Foundation, and we were fortunate enough to get some government grant to help us to even prove our point. Now, it isn't only just the family that's involved. It is also the care for loved ones and Also, we're tied in with the medical care center as well, so counseling. And then also comprehensive assessments, which also assesses that individual of who and what is a part of their brain that is ticking and how the brain works. But here's a quote, and this was from the very first one that we did as a pilot. And this was her note that she handed in with a thank you card. I have done so much work to deal with my mom, and this is the first time ever I feel it has stuck, and I got true, sustainable results. There's one other one that I didn't know about, because the Thumbs Up Foundation does a lot of survey, does their own little survey, and it's rated, and all the ratings are done through these 11 that I'm on the 11th one now. But here's one that I did not know about until I saw the list of it. And it said, this is the only program that has worked or been helpful from our family. We have been through private psychology and other resources, all of which were not helpful. It works and it's helping. And that is my mission, is to keep going, because more than ever in this pandemic, families are huddled together, school, work, and home. And challenges are happening. But boy, if they have the tools, it makes a huge impact. So it's about families does play a critical role in creating an environment of change. All of you today can make that difference. And there's one tip I'll leave you right now is love, L-U-V. Listen, understand. Just reflect back what you heard to see if you've understood them. And validate your loved one, the things that they're doing right. That's one thing my daughter was always needing, was that confidence builder, that there was something right. And I'm grateful for our journey, because we are trying hard to keep making that difference happen for families. Back to you, Dara.
Thanks, Mona. I appreciate the candor and the intimacy of your story, and the handy acronym, LUD. I think I can keep that in my head. Next, we're going to turn to Jason Mercredi, who does some amazing work, I hear, as he leads the team at Prairie Harm Reduction in Saskatoon, which is a clean place for people to safely consume drugs under the supervision of staff who can offer social supports. Jason's going to talk to us about how rising mental health issues have contributed to a record number of overdose deaths in Saskatchewan, prompting health officials to deem it a crisis. With no new provincial funding, the organization is relying on small businesses and public fundraising to keep the doors open, which I'm sure is a familiar story to many in the community. Jason, I'm going to pass it over to you.
Yeah, thank you for having me. So I'm just going to open up my slideshow. Can people see that? Perfect. All right, so philanthropy in addressing Canada's overdose crisis. So our service is Prairie Harm Reduction. We're located in Saskatoon, Saskatchewan, and we operate a number of programming. So the first one that we operate is the Family Support Program. They run an outreach team, a youth home, and the Oski Kisikau apartment that we're opening up next month. That's going to be reuniting parents who have lost their kids to the foster care system with their kids, and so we're going to be taking kids out of foster care and reuniting them with their families. That's something we haven't announced publicly yet, but we're pretty excited about it. We also have our support services department that does outreach, case management, naloxone training, operates our safe consumption site, and our drop-in center. So we operate quite a large number of services, and we do it on a fairly thin budget, which I'm sure is pretty commonplace for all of you. And we prioritize hiring people with lived experience, whether that's people who are Indigenous, people who have experienced homelessness, people formerly living with addictions or currently living with addictions. We try to hire people with lived experience as best we can. That said, all of our staff are paid the same wages. We don't have a staffing wage discrepancy if you're quote unquote a peer versus a non-peer staff. And we think that that allows us to retain people and recruit people in a much more holistic way. So safe consumption sites. So for those of you who don't know, Canada's in the midst of overdose crisis. A lot of people are dying. A lot of people are dying. And so we're in this weird spot where we need services like ours. Ours is a safe consumption site. So what is a safe consumption site? It's basically a federally approved a building where people can come and use drugs under the auspice or the observation of a medical professional. Our safe consumption sites are federally approved. They're provincially funded in theory. And some major cities fund these services. So Toronto and Vancouver kind of being the main two, as those cities control health spending. But you see that there's an immediate disconnect between the fact that the federal government approves it and the provincial government is expected to fund it. And so, across the prairie provinces in Ontario, you have very hostile provincial governments to the federal government and vice versa. And so a lot of times people don't want to do it because they can't take all the credit for it, or there's an ideological difference. And so, we have hostile governments in Alberta and Ontario. We have reluctant governments to fund these services in Saskatchewan and Manitoba. And I say there is a difference there because in Alberta and Ontario, they're actively trying to cut funding for different programming. And in Saskatchewan and Manitoba, they're just like kind of hands off and not providing financial support to these types of programming and even for ours. So we do receive provincial funding for our case management programs, but we don't receive any funding for our safe consumption site. So it leaves us in this really big limbo where we're expected to watch people die because of an ideological difference, and people don't want to fund it at the provincial level. So why did our organization need to open up a safe consumption site? So one is we've historically, Saskatchewan has the record HIV rates in all of Canada. So we had 199 new infections in 2019. That was an 18% increase. What makes us very unique is that we're the only province that the main mode of transmission for injection or for the HIV transmission is shared drug equipment. We have approximately 26% of people living with HIV not aware that they're positive in Saskatchewan, and that's really not great because it shows that we're not doing a good job of connecting with these folks. And it's important that we do, because when people are aware of their HIV status, they're much more likely to change their behaviors and reduce risk so they don't expose somebody else to this problem. So our building, we relocated from the neighborhood of Mayfair to Pleasant Hill in 2019. We bought a new building. It was ideally situated. We're located by pretty much every service provider you can want to be located to if you're going to want to operate one of these buildings. We're right in between the Westside Community Clinic, which is run by the Saskatoon Community Clinic, and it's the busiest clinic that works with people who use drugs or people living with HIV in Saskatchewan. And then on the other side of us, we have the Saskatoon Tribal Council Health Center, which is the busiest needle exchange in the entire province. So we're situated literally in between it. It goes Saskatoon Tribal Council Health Center, with their needle exchange, us, and then the Westside Community Clinic. We're also just down like a kitty corner to Brief and Social Detox is through our alley. St. Paul's Hospital is half a block away. Sanctum, which is a HIV hospice, is a half a block away. We have Orr's Clinic and the Positive Living Program. So we have an rapid access methadone clinic, kitty corner to us. So we're really where we need to be. And even with that, we couldn't get provincial funding. So not just to where we need to be, but here's a map. So down in the bottom blue corner on the bottom is Pleasant Hill. That's where a majority of overdoses were happening. And if you look at the top of the map, it says 2018. It maps out the overdoses for all of 2018, where people had to be brought to the emergency room. There's only 245. The last public available data we had for overdoses, not overdose deaths in Saskatoon, we were dealing with upwards of 150 a week. It was about 120 on average. And so that gives you an idea of how bad the problem's gotten when we've gone from 245 a year to 120 on average a week in just 2 short years. Then we asked people who use drugs where they'd like to be located, and overwhelmingly the location was in the bottom left there with St. Paul's Hospital. You can see the Saskatoon Tribal Health Center. We're located right beside that location. Our old location and our old name is at the top with Aid Saskatoon. And a lot of our folks said that they would like us to operate the site, which is why they chose us as one of their preferences. But we realized through the survey the majority of our clientele were actually living in Pleasant Hill. So it made sense for us to move our location down there. Then we look at historic HIV rates, overwhelmingly Pleasant Hill. So we're ideally situated. We're right in the heart of the HIV epidemic. We're right in the heart of the overdose crisis. And we're where clients want us, and yet we still couldn't get provincial funding. For us, I'm just going to go quickly through this. Transparency was key right from the start. So we did a community consultation. We wanted to maximize local contribution and minimize outsider contribution. By that, we didn't want people that didn't live in Pleasant Hill to be talking about solutions for Pleasant Hill. The Pleasant Hill is predominantly, well, it's the most impoverished neighborhood in the city, predominantly Indigenous, and a lot of people tell Pleasant Hill what they want, and we didn't want that to take place. And so we maximized Pleasant Hill's contribution and minimize the outsider contribution. The one thing when you're doing these types of projects, whoever's leading the projects need to be at everything. So that's me. And so I'm at community meetings all the time. I'm online. People see me in the media. I try to be as active as possible to talk about this because people need to know that there's somebody responsible for these types of sites when you're wanting to engage the public. We educate the community. We use traditional media, but we really do maximize social media. I was going to put some of our memes on there, but they're probably a little bit too racy for this presentation. But our use of social media has allowed us to be the success that we are today, and it's part of a media strategy and public engagement strategy. But we use social media because a lot of times what we find when you're talking about mental health is when you use traditional media, they misrepresent, or they use stigmatizing language, or they don't get the proper messaging out. So let's just cut out the middleman and we go after it. That said, we have really good media relationships, and our media in Saskatoon is really well informed on the overdose crisis and mental health crisis. And you know, we're pretty active in working with them to make sure that they're using the proper language and they're not further stigmatizing the population. And it's really allowed us to get all segments of the population to engage on this issue. So we did a door knocking campaign through community consultation. I'm not going to bore you with the details, but basically we knocked on every house in Pleasant Hill, and it took us 2 months. 74% of residents were in favor, which shocked a lot of people. 15% opposed, 11% neutral, 27 organizations in favor, 3 opposed, 5 were neutral. 87% of people used drug surveyed in 2018 stated they would use it as a safe consumption site, and that Pleasant Hill is the preferred location. We have 7 booths for injecting, ingesting, and snorting, and we have 1 booth for safer smoking. We're now the only booth for safer smoking in the country. This isn't just a free-for-all. People come in. It's a very sterile facility. This is a terrible photo. It's very blurry, but it's a very sterile facility. If you walked in, it looked like any other medical clinic. And we did that intentionally when we're working with folks so that we could get better buy-in from the mainstream on it. And now we're working on, you know, putting some graffiti tags up and different types of art up. But the space is a federally regulated facility, and I think we have one of the best ones in the country. We're just not funded. And so creative funding options are needed. And so we really relied on social enterprising at the start because we didn't think in Saskatchewan, we didn't think harm reduction was going to be a catchy or something that people wanted to back. It's very, you know, harm reduction can be viewed as very controversial. And so we focused on a online clothing store. What we didn't know when we did the online clothing store is that really ingratiated us with places like the Chamber of Commerce and the business community, because we're now running a small business. And so running a small business is hard. I can tell you that from running this store, it's brutal. And so they really liked our approach, and they liked the fact that we were engaging through social enterprise. We were denied funding in 2020 and 2019, and we became fairly aggressive in our advocacy approach. And the money started pouring in once we started becoming aggressive in our advocacy approach. Basically, we thought, what's the point of being polite? Polite got us nowhere, so let's fucking go after it. Sorry, I didn't mean to swear, but let's go after it. And so we have been. And as a result, we've had a lot of success. But a lot of it's based around our social enterprise. So these are blankets, but these are designs that we used on bunny hugs or hooded sweatshirts, t-shirts, blankets, beach towels, you name it. We've done a lot, and we do limited edition runs, and we try to have a message on our clothing. So you can see this is from our tarot card design that we did about 1.5 years ago. Here's our justice one that brings awareness to missing and murdered Indigenous women. One of the things that we do with all of our lines is we always donate. We pick one of our designs and we donate 50% of all the items with that design on it to another nonprofit or charity. And so this one was for Chokecherry because they do a lot of work on Chokecherry youth, Chokecherry Studios, because they do a lot of work with youth in the community on missing and murdered Indigenous women. And that was designed by one of their youth as well. This is our judgment one. So one of our moms in the community, Maria Jarides, she lost her son to an overdose. We asked if we could use him for the angel messaging, and it really allowed this like powerful message to come through about how the human toll this has on it, and what she's been able to do with his legacy and really rally the community, because she's kind of a titan in our city for the awareness campaign. And so it shows people rising from a wheat field. This is one of our ones from our newer designs. So it's just a fun design, be heard. It has naloxone on it. Courage and advocacy. Here's one of our ones that is based off of Akira, which is an anime, really cowboy themey, futuristic theme. Got a lot of people interested. And then we had a raccoons theme one that was, we're really looking to get the college kids that are partying. And then as a result, we were able to raise $180,000 in 1 month. So this is just from April of this year. We didn't plan a fundraising. We planned our clothing store, which we were guessing we were going to raise around $20,000 to $30,000, and then our estimating. And then the business community, when we got denied provincial funding, really rallied behind us, which was surprising to us because we now have an official realtor. There's a butcher shop that runs a line of smokies for us. We have a nerd store that sells socks for us. We had cinnamon buns, we had tattoo parlors, drag shows, fitness classes, you really name it, we've had everything. A movie theater just did dedicated popcorn sales for the month to us, and we were able to raise a lot of money. And really, we didn't plan any of it, which was amazing for us. So the future for addressing the overdose crisis, the big question is sustainability. I can tell you from trying to fundraise as much money as we need to operate one of these facilities is it's brutal. Like it takes everything you got, and the time commitment is no joke. So that I can pay my staff, I'm probably working 60 to 80 hours a week most weeks. It's pretty intense. So we're hopeful that we're going to get provincial funding, and if not, we're going to be doing more social enterprises. So the store is kind of just the start of it, and then the digital aspect of what we do with our fundraising and community engagement, community education, can't be understated. And we don't have anybody on staff that does that, and so I do that as well. And so really that push and that drive to get this thing off the ground has been what's carried us forward. And luckily the community's backed us, but you know, we're not sure how long that's going to be able to keep going. And so we're very hopeful for provincial funding in the future. These are just some advocates across Canada that are working on this very important issue. Is this is a legitimate life or death issue when you have, you know, 2,000 plus people dying in some provinces a year, and 20,000, you know, and it's just the death toll is starting to get pretty intense, and it's taking its toll on staff and community members and family and friends. So that, I'll say thank you.
Wow. Thank you, Jason. It's clear how dedicated you are to this work and the creativity you're infusing into how to get the message out, how to raise dollars. I am looking forward to checking out your racy social media. That was too racy for this presentation. In the comments, I see that someone's complimenting your memes, so I will definitely check those out. All right, our final presentation is from Alexa Joy, who's going to talk to us about Project HEAL, a community group support program in Winnipeg, in Manitoba. It's facilitated by Black healthcare professionals, social workers, and counselors. And Project HEAL provides support to Black people who are experiencing mental health concerns from the effects of systemic racism, violence, and dealing with the trauma from anti-Black discrimination. Alexa, I'll pass it to you.
Hi, everyone. Thanks again so much for having me. I'm gonna share my computer in one sec, but yeah, I just wanted to give a quick and brief, I guess, rundown of Project HEAL, why it started, and the need for it. So, you know, we've heard from great speakers from across the country, but if anyone has ever been to Manitoba, I think you know the both isolating experience it can create, not just in our weather. We all know in Canada it's freezing, but Manitoba can get devastatingly cold, but also the cultural isolation that happens across Canada. Just to give you an example, I believe the statistics say that there are 80% of Canada's Black population who identify and present as Black live within Ontario. So that means the other 20% are sprinkled throughout the rest of Canada. And Manitoba, I think we just reached over 4 to 4.5% of the Black population in Manitoba made of the population overall. So in 2018, there was a lot of discussion happening around mental health resources, or rather lack thereof, that were culturally sensitive and significant to different communities. With the amount of anti-Indigenous racism that exists in Manitoba, the work that we were doing with Black Space Winnipeg was kind of really building from this misconception that first, Black people didn't exist in the prairies, and second, that we were also a happy utopia, multicultural, those common sentiments that are conveyed in a Canadian discourse, that racism does not exist up here. But as we've all seen, whether in the discourse of Black Lives Matter, or anti-Indigenous racism or Islamophobia, that racism, systemic white supremacy is quite real within our country's borders. So with that, we got tired of, the lack of just basic resources for counseling and, like we said before, culturally relative and sensitive support groups in our city for Black people. So we started our work in 2016, but fast forward 2 years later in 2018, we really wanted to, tackle this systemic barrier of access to therapy and to counseling. So I know it's a bit, I'll use those words interchangeably. I know that you can't, but roughly, we couldn't call ourselves a therapy group because we were inviting registered therapists or coaches or social workers to come speak to our group, but at the same time, we weren't really we couldn't offer therapy because we weren't, a licensed organization to do so. But we realized the, kind of imperative position we were in to really, address these issues. So as it was said before, Project HEAL, we were a group that really wanted to get to the social implications and influences on Black mental health. And in Winnipeg, there was nothing at the time that really existed for Black mental health, and to provide not only a healing space, but a safe space for Black people to just come, share their experiences, learn how to cope with these, challenging mental health concerns, and, offer support to each other. So we ran this program for successfully for 2 years. And we took a bit of a hiatus in between 2019 and 2020 because I'm a grad student, so I left Winnipeg for school, obviously. And then, last year, with the amount of, and this is where we rebooted the program, with the overwhelming displays of anti-Blackness, not just in Canada, but internationally, we really wanted to offer an online safe space for Project HEAL and to kick off our group again. But it was very difficult, as I'm sure we've all experienced, running online programming in a nonprofit setting or a grassroots collective has not been the easiest to do, especially, you lose a real sense of community almost, and that intimacy that you can do with in-person programming. So the online wasn't the ideal, but it was, what we had to work with, because there were so many just concerns about, what do we do now? This was the big question post George Floyd was, there was this undeniable attention that we could no longer sweep things under the rug. And, you know, what I think last summer achieved in that sense was this like revitalization of, you know, how Black trauma continued to trend, and then the lack of institutional, provincial, federal resources that are really out there to help people. So let me just share my screen. Okay, so I just wanted to play this video. This is Nedu Ajekam and Leslie Hackett, who are now the current facilitators of Project HEAL. It started first with Sapphire McLeod and Nedu, and Leslie on the left is a registered family and marriage counselor, and Nedu is a social worker, also to do his master's at U of T. So, you know, the Prairies always loses people to Ontario. I don't know what happens in other parts of Canada, but we're trying to reshift. But let me refresh this so you can just hear kind of where Project HEAL is at right now.
I'm one of the co-facilitators for Online Project HEAL. I'm Leslie Hackett. I'm the other co-facilitator of Project HEAL. And I'm really looking forward to talking about Blackness and wellness and how they influence each other. Some of the topics we'll be talking about will be coping with trauma and challenges to mental health, healthy relationships and communication, and dealing with racism. We're really excited to do this program. We've got a lot of other professionals, therapists, and social activists that are going to be joining us for this program. So yeah, we're really excited. We think it's going to be great.
Okay, so I wanted to share that just to give you kind of a heads up of where.
My name is Nedu Ajekam, and I'm one of the.
Of where we're at with Project HEAL. Right now, I've obviously stepped back from the program, but what Nedu and Leslie are trying to achieve is really this institutionalization of Project HEAL, because as I'm sure people on this call who have experience in either community work or activism or, you know, grassroots, radical, whatever, it's exhausting and it'll burn you out, and you can only do so much for so long without institutional support, resources. There are, I don't know how many, I think almost 10 different organizations that are dedicated to either counseling services, therapy, or mental health in Manitoba, and zero really had any specific programming or services for, you know, Black mental health and or Indigenous and other people of color, and the lack of support was really alarming, which is why, you know, we take matters into our own hands. This is what we do as radical practitioners and activists and, you know, dedicated social workers. When you don't see what's happening on an institutional level, you know, you make those pivots and systemic changes as you need to. So Leslie and Nedu are advocating right now for funding. And as mentioned in the previous presentation, you know, a lot of the attention that we had last year in the wake of George Floyd, and I've been saying this both with my work at CBC Manitoba and at the New School where I research, is it was really a summer of white guilt, and a lot of white people threw money at different nonprofit organizations and were like, oh my gosh, yes, Black Lives Matter, here's $2,000 and, you know, good luck. And unfortunately, that was great for the time that we had their attention, but it's not sustainable, right? And on a federal level, there has been different funding for like Black mental health initiatives. I think out of the Economic and Social Development Canada, there were a few pools of funding that we applied for and were unsuccessful. And it's really funny that we were unsuccessful because we were actually doing the work. We had safe space policies. We brought in everyone from registered sex therapists to marriage counselors to life coaches to nutritionists. We really took the idea of mental health in all of its, you know, all of its elements. You know, we didn't just want to talk about that. Yes, we were connecting it to here are the mental health challenges of systemic white supremacy, of anti-Blackness, but also giving people the tools to heal themselves, whether that was through creative art. We had an artist came in, we did an art night, we did music, we touched on music therapy, like I said, nutrition and diet, coaching, life coaching, like what we know what the problems are, where can we focus our attention, and how do we get to a better place of healing? And relationships. We just really wanted to tackle every area we could think of mental health. And at the feedback, the surveys from the program really conveyed the sense of kind of what's the word I'm looking for? Like a made family. Like there was this great quote one participant had that said, "We came as strangers and we left as family." And in our first year, we had 14 participants, and all from the diaspora. We were really conscious that we didn't just want this to be a predominantly Black Caribbean space, or like newcomer West Africans. You know what I mean? It was like, if you identify as Black under the umbrella, under the diaspora, if you were queer, if you were straight, come as you are. We're going to really heal together as a collective and learn as a collective. We were really passionate about sharing this idea of, making new connections in the Black community in Winnipeg, because as I'm sure it is throughout, different parts of the country, and from like my personal experience, the Black population in Manitoba, it's very spread out. Like other than the downtown central and like the inner city community, everyone's pretty much in their own silos in a sense. So we really wanted to bridge that gap. Also across of age, we had our participants were from as young as 23 and as old to 70. So we almost had this, we did have this intergenerational sense of healing as well. And even the practitioners who came in, they're like, where was this in the 80s and the 90s and the early 2000s? And I think what's really powerful too through our work is that, and what's really alarming, and I think that what we're all trying to do in our work is this constant convincing the provincial and federal government, like, hey, we really need these resources and you can't do it. So, give us the funding so we can. But it's a constant struggle to try to convince people in, the powers of authority and, who are writing the checks and granting the funding to really get on this bandwagon that we need support. It's fundamental. And where I know Leslie and Nadu are at now is really working with the Winnipeg Foundation and trying to get somewhat of an operational funding to support Project Heal on an annual basis. And then from last year, we launched our online Project Heal. So that was about, I think they had 10 participants. I was there in the beginning, but again, school took over. But same thing, like just the shared safe space. And really too, I think the biggest theme, just want to make sure I'm not going over time, that came out of Project Heal was just this, validating one's experience. When you're in a culturally isolated community, dealing with all types of systemic and social barriers, it means so much when you come to a space either in person or online and someone validates, where you're coming from. I think that's you can't buy that. It's so important. And the fact that I know like there are different organizations in the city, like mental mood disorders Manitoba, Clinic with a K, Canadian Mental Health Association, I believe it's called. There's different organizations and subchapters, but still like this kind of Eurocentric approach to what therapy and health is, and just the lack of Black practitioners. There are people I know last year in the wake of George Floyd, there's a lot of resources coming out online and a lot of like digital literacy that just gave people the location, like here are 10 registered Black therapists in Manitoba that you need to know. And you know, it's still so concerning and disheartening that, you know, these institutions that are, you know, federally, provincially funded and mandated to serve the, you know, Winnipeg or Manitoba population for mental health still have this real lack of, you know, how mental health looks like in different communities, how different cultures and communities heal, and what, you know, never really connecting the systemic barriers and social disparities to the discourse of mental health. I think that's incredibly disturbing. And if anyone's paying attention to, Manitoba just made the New York Times for like the worst province in the country for COVID-19. And, you know, the mental health, we've all seen the systemic, you know, fragments really be exposed during the pandemic. And I think what COVID-19 is also illuminating is that our structure, first, it never worked. It's not working, and it cannot continue to, you know, go like this. And, you know, in the pandemic, I think that we're also really struggling to have these consistent resources, because I know my mental health has suffered. I'm sure everyone on this call, it's not normal to stay in your house all the time. And just like, you know, life, you know, it will never go back to normal. And thank God that it won't, because what we were dealing with before wasn't any better now. And really kind of also in Project Heal, bringing in this idea now in the pandemic that, you know, racism and anti-Blackness is a health crisis for real. So that's kind of where we're at right now, trying to secure this operational sustainable funding, which is definitely easier said than done. But you know, nothing that's, you know, people kind of ask us, like, how do you continue to do this work? And, you know, the short answer is you can't stop. There's people suffering in all communities, but, you know, in the Black community in Winnipeg, I think that there's so much more, not just in Manitoba, but across the country, that needs to be done, both in the recognition of Black mental health, the advocacy, you know, and providing the resources, the real ongoing accessible resources to mental health. So that's kind of where we're at now.
Thanks, Alexa. I can also hear the passion in the work that you're doing. In fact, from all of our presenters today, it both enrages me that there are not enough resources to invest in this critical work, and simultaneously I'm inspired by the commitment of folks on the ground to persevere and be creative in terms of delivering this necessary work. And we have 4 minutes left. So I think I just want to quickly ask if there's anybody that that spoke today that has a burning thing they need to share before we wrap up.
Yeah, I thought one of the overriding things that we discovered, and I probably don't need those, Kim, that's fine, is that I think what we discovered was that COVID actually just brought into more clear focus, like many of you have stated, issues that were likely pre-existing prior to COVID, and highlighted the populations at risk even more so. And so when we look at that, and from a college perspective or an institution of education, and looking at the role of philanthropy in meeting the needs of our communities, we really felt that we needed to pay more attention or put a lot of effort into actually building humanitarian competencies within our health and human services students. And then how do we do that? And so looking forward in how both Selkirk College wants to work with IRIS and maybe other community organizations, nonprofit organizations in the future, is really looking at how can we start to embed these community-based learning experiences for students. When they can get in to the community, they can start assessing what the needs of the communities are right at the front line with the people that are doing the work, and then actually working with those institutions to actually deliver services to meet the needs. And I know for many colleges and universities send their nursing students, for example, and other students out to third world countries to help in humanitarian efforts. But I really think what the message from today is, from everybody who's presented, is that we have a huge need within our own country, and a huge need to build capacity within our own country to help meet the needs of our population. So moving forward, we're really excited. I would really love it if any of you don't know Sandy McCrate and what she does through IRIS and Castlegar, to touch base with her, to learn about what we're doing and where we would like to take this in future. The other thing is that what has come out of this is the importance of connection. And I think you've all spoken to that today. The importance of making, creating relationships and creating bonds. And I think the acronym LOVE would likely fit in all of the different situations we've talked about today. We certainly have found that both with ourselves in the research that we've done and the projects we've done, our own perspectives have changed, as well as our student perspectives have changed. And one of them is it isn't us and them, it's us as them. So seeing how the people that we are serving are actually very much tied to who we are, and that we're not two distinctly different entities in the social context. So I think I just wanted to end with that. I think that there's a huge need to really grow that type of competence within our institutions, within our education systems, and just grow the passion for that type of work. So I'll leave it at that.
Thanks, Katrina.